The human heart is a remarkably efficient, durable, and reliable pump, propelling more than 7,500 L of blood through the body each day, and beating more than 40 million times a year, the wellspring for tissue oxygenation, nutrition, and waste removal. In utero, the heart and vasculature are the first fully functional organ system. Without a vascular supply and a beating heart, further development cannot occur and fetal demise is inevitable. When the heart fails postnatally, the results are equally catastrophic. Cardiovascular disease is the #1 cause of worldwide mortality. In the United States alone, cardiovascular disease accounts for roughly 1 in 4 of all deaths, totaling about 610,000 individuals each year, greater than the number of deaths caused by all forms of cancer combined. This chapter begins with a brief review of the normal heart because most cardiac diseases manifest as structural and/or functional changes in one or more cardiac components. General principles underlying cardiac hypertrophy and failure, common endpoints of several of the different forms of heart disease, are also discussed before exploring the major categories of cardiac disease: congenital heart abnormalities, ischemic heart disease, hypertensive heart disease, diseases of the cardiac valves, and primary myocardial disorders. The chapter concludes with a few comments about pericardial diseases and cardiac neoplasms, as well as cardiac transplantation and devices. 527. Cardiac structure and specializations. Heart weight varies with body habitus, averaging approximately 0.4% to 0.5% of body weight. Increased heart weight or ventricular thickness indicates hypertrophy, and an enlarged chamber size implies dilation. Both reflect compensatory changes in response to volume and/or pressure overloads. Increased cardiac weight or size, resulting from hypertrophy and/or dilation, is called cardiomegaly. Myocardium. The pumping function of the heart occurs through coordinated contraction and relaxation of cardiac myocytes. Left ventricular myocytes are arranged in a spiral circumferential orientation to generate vigorous coordinated waves of contraction spreading from the cardiac apex to the base of the heart. In contrast, right ventricular myocytes have a less structured organization, generating overall less robust contractile forces. Contraction is achieved by shortening of serial contractile elements within parallel myofibrils. Although the heart is primarily a pump, it is worth remembering that it also has other functions. For example, atrial cardiomyocytes have cytoplasmic storage granules that contain atrial natriuretic peptide, and ventricular myocytes contain B-type natriuretic peptide. Both of these are protein hormones that are released in response to increased stretch. They both promote arterial vasodilation and stimulate renal salt and water elimination. Valves. The 4 cardiac valves, tricuspid, pulmonary, mitral, and aortic, maintain unidirectional blood flow. Valve function depends on the mobility, pliability, and structural integrity of the leaflets of the atrioventricular valves or cusps of the semilunar valves. The function of the semilunar valves depends on the integrity and coordinated movements of the cuspal attachments. Thus, dilation of the aortic root can result in valvular regurgitation. In contrast, the competence of the atrioventricular valves depends on the proper function not only of the leaflets but also the tendinous cords and the attached papillary muscles of the ventricular wall. Left ventricular dilation, a ruptured cord, or papillary muscle dysfunction can all interfere with mitral valve closure, causing valvular insufficiency. Cardiac valves are lined by endothelium and share a similar, tri-layer architecture. Fibrosal layer, a dense collagenous layer at the outflow surface, connected to the valvular supporting structures and providing mechanical integrity. Spongiosal layer, a central core of loose connective tissue. Ventricularis or atrialis layer, a layer rich in elastin on the inflow surface, providing leaflet recall. Because they are thin enough to be nourished by diffusion from the blood, normal leaflets and cusps have only scant blood vessels limited to the proximal portion of the valve. Valve endothelium also does not express ABO or histocompatibility antigens, so cryopressor valvular tissues can be transplanted with relative impunity. Conduction system. Coordinated contraction of the cardiac muscle depends on the initiation and rapid propagation of electrical impulses, accomplished through specialized myocytes in the conduction system. The frequency of electrical impulses is heart weight varies with body habitus, averaging approximately 0.4% to 0.5% of body weight. Increased heart weight or ventricular thickness indicates hypertrophy, and an enlarged chamber size implies dilation. Both reflect compensatory changes in response to volume and/or pressure overloads. Increased cardiac weight or size, resulting from hypertrophy and/or dilation, is called cardiomegaly. Myocardium. The pumping function of the heart occurs through coordinated contraction and relaxation of cardiac myocytes. Left ventricular myocytes are arranged in a spiral circumferential orientation to generate vigorous coordinated waves of contraction spreading from the cardiac apex to the base of the heart. In contrast, right ventricular myocytes have a less structured organization, generating overall less robust contractile forces. Contraction is achieved by shortening of serial contractile elements within parallel myofibrils. Although the heart is primarily a pump, it is worth remembering that it also has other functions. For example, atrial cardiomyocytes have cytoplasmic storage granules that contain atrial natriuretic peptide, and ventricular myocytes contain B-type natriuretic peptide. Both of these are protein hormones that are released in response to increased stretch. They both promote arterial vasodilation and stimulate renal salt and water elimination. Valves. The four cardiac valves, tricuspid, pulmonary, mitral, and aortic, maintain unidirectional blood flow. Valve function depends on the mobility, pliability, and structural integrity of the leaflets of the atrioventricular valves or cusps of the semilunar valves. The function of the semilunar valves depends on the integrity and coordinated movements of the cuspal attachments. Thus, dilation of the aortic root can result in valvular regurgitation. In contrast, the competence of the atrioventricular valves depends on the proper function not only of the leaflets but also the tendinous cords and the attached papillary muscles of the ventricular wall. Left ventricular dilation, a ruptured cord, or papillary muscle dysfunction can all interfere with mitral valve closure, causing valvular insufficiency. Cardiac valves are lined by endothelium and share a similar, tri-layered architecture. Fibrosa layer, a dense collagenous layer at the outflow surface, connected to the valvular supporting structures and providing mechanical integrity. Spongiosa layer, a central core of loose connective tissue. Ventricularis or atrialis layer, a layer rich in elastin on the inflow surface, providing leaflet recall. Because they are thin enough to be nourished by diffusion from the blood, normal leaflets and cusps have only scant blood vessels limited to the proximal portion of the valve. Valve endothelium also does not express ABO or histocompatibility antigens, so cryopressor valvular tissues can be transplanted with relative impunity. Conduction system. Coordinated contraction of the cardiac muscle depends on the initiation and rapid propagation of electrical impulses, accomplished through specialized myocytes in the conduction system. The frequency of electrical impulses is sensitive to neural inputs, extrinsic adrenergic agents, hypoxia, and potassium concentration. The components of the conduction system include the following. Synovial node pacemaker, at the junction of the right atrial appendage and superior vena cava. Atrioventricular node, located in the right atrium along the interatrial septum. Bundle of His, connecting the right atrium to the ventricular septum. Right and left bundle branch divisions that stimulate their respective ventricles via further arborization into the Purkinje network. The cells of the cardiac conduction system depolarize spontaneously, potentially enabling all of them to function as cardiac pacemakers. Because the normal rate of spontaneous depolarization in the SA node is faster than the other components, it normally sets the pace. However, if nodal tissues become dysfunctional, other cells in the conduction system can take over, generating, for example, the junctional escape rhythm. The AV node has a gatekeeper function. By delaying the transmission of signals from the atria to the ventricles, it ensures that atrial contraction precedes ventricular systole. Blood supply. Cardiac myocytes rely almost exclusively on oxidative phosphorylation for their energy needs. Besides a high density of mitochondria, myocardial energy generation also requires a constant supply of oxygenated blood, rendering myocardium extremely vulnerable to ischemia. Nutrients and oxygen are delivered via the coronary arteries, with ostia immediately distal to the aortic valve. These initially course along the external surface of the heart and then penetrate the myocardium, subsequently branching into arterioles and forming a rich arborizing vascular network so that each myocyte contacts roughly 3 capillaries. The right and left coronary arteries function as end arteries, although anatomically most hearts have numerous intercoronary anastomosis. Blood flow to the myocardium occurs during ventricular diastole, after closure of the aortic valve. Overview of cardiac pathophysiology 529. When the microcirculation is not compressed by cardiac contraction. At rest, diastole comprises approximately 2/3 of the cardiac cycle. With tachycardia, the relative duration of diastole also shortens, thus potentially compromising cardiac perfusion. Cardiac regeneration. There is considerable interest in exploring the possibility of replacing damaged myocardium by inducing cardiac regeneration in vivo or implanting stem cell-derived cardiac cells. Although cardiac regeneration in metazoans such as newts and zebrafish is well described, the myocardium of mammals has a very low replicative potential after fetal and neonatal life, averaging less than 1% cardiomyocyte turnover per year in adult humans. Increasing evidence, however, indicates that cardiomyocyte proliferation can be augmented in mice. The potential for stimulating cardiac regeneration in vivo in humans is tantalizing because it could facilitate recovery of myocardial function after a host of injurious stimuli. Another area of vigorous investigation is ex vivo expansion and subsequent administration of stem cell-derived myocardial cells into areas of myocardial injury. Unfortunately, results thus far have been less than exciting. Implanted cells may show some cardiomyocyte differentiation, but the durability of this benefit has been limited, and they do not contribute significantly to the restoration of contractile force. Moreover, failure to successfully integrate these cells into the conduction pathways of the host heart carries the very real risk of autonomous arrhythmic foci. Effects of aging on the heart. Most forms of heart disease become more prevalent with each advancing decade. Consequently, as the average populations in high-income countries get progressively older, aging-associated changes in the cardiovascular system become ever more significant. The size of the left ventricular cavity, particularly in the base to apex dimension, is reduced in later life. This volume change is exacerbated by systemic hypertension as the basal ventricular septum protrudes into the left ventricular outflow tract. Compared with younger myocardium, the elderly heart typically has fewer myocytes and increased connective tissue. Octogenarians also frequently have deposition of extracellular amyloid that stiffens the heart and reduces diastolic filling. Valvular aging changes are major contributors to significant valvular disease, and progressive atherosclerosis, with a strong aging component, is the major cause of IHD. Overview of cardiac pathophysiology. Although a host of diseases can affect the cardiovascular system, the pathophysiologic pathways that result in a broken heart distill down to 6 principal mechanisms. Table 12.1 Changes in the aging heart chambers increase left atrial cavity size, decrease left ventricular cavity size, sigmoid-shaped ventricular septum. Valves. Aortic valve calcific deposits, mitral valve annular calcific deposits, fibrous thickening of leaflets, buckling of mitral leaflets toward the left atrium, lambeal excrescences. Epicardial coronary arteries. Tortuosity, diminished compliance, calcific deposits, atherosclerotic plaque, myocardium, decreased mass, increased subepicardial fat, brown atrophy, lipofuscin deposition, basophilic degeneration, amyloid deposits. Aorta, dilated ascending aorta with rightward shift, elongated thoracic aorta, tubular junction, calcific deposits, elastic fragmentation and collagen accumulation, atherosclerotic plaque. Failure of the pump. In the most common situation, the cardiac muscle contracts weakly and the chambers cannot empty properly, so-called systolic dysfunction. In some cases, the myocardium cannot relax sufficiently to permit ventricular filling, resulting in diastolic dysfunction, obstruction to flow. Lesions that prevent valve opening or cause increased ventricular chamber pressures can overwork the myocardium, which has to pump against the obstruction. Regurgitant flow. Valve pathology that allows backward flow of blood results in increased volume workload and may overwhelm the pumping capacity of the affected chambers. Shunted flow. Defects that divert blood inappropriately from one chamber to another, or from one vessel to another, lead to pressure and volume overloads. Disorders of cardiac conduction. Uncoordinated cardiac impulses or blocked conduction pathways can cause arrhythmias that slow contractions or prevent effective pumping altogether. Rupture of the heart or major vessel. Loss of circulatory continuity may lead to massive blood loss, hypotensive shock, and death. Most cardiovascular disease results from a complex interplay of genetics and environmental factors. These can disrupt signaling pathways that control morphogenesis, affect myocyte survival after injury, or affect contractility or electrical conduction in the face of biomechanical stressors. Indeed, the pathogenesis of many congenital heart defects involves an underlying genetic abnormality whose expression is modified by environmental factors. Moreover, genes that control the development of the heart may also regulate the response to various forms of injury, including aging. Cytopolymorphisms can significantly affect the risk of many forms of heart disease, and, as discussed later, a number of adult-onset heart disorders have a fundamentally genetic basis. Thus, cardiovascular genetics provides an important window on the pathogenesis of heart disease, and molecular diagnoses are increasingly a critical part of its classification. Heart failure. Heart failure, often called congestive heart failure, is a common, usually progressive condition with a poor prognosis. Each year in the United States, CHF affects more than 5 million individuals, necessitating more than 1 million hospitalizations and contributing to the death of nearly 300,000 people. Roughly 1/2 of patients die within 5 years of receiving a diagnosis of CHF, and 1 in 9 deaths in the United States include heart failure as a contributory cause. Heart failure is defined as the condition in which a heart cannot pump blood to adequately meet the metabolic demands of peripheral tissues, or can do so only at elevated filling pressures. It is the common end stage of many forms of chronic heart disease, often emerging insidiously from the cumulative effects of chronic work overload or IHD. However, acute hemodynamic stresses, such as fluid overload, abrupt valvular dysfunction, or myocardial infarction, can all precipitate sudden CHF. When cardiac workload increases or cardiac function is compromised, several physiologic mechanisms swing into action and can at least initially maintain arterial pressure and organ perfusion. Frank Starling mechanism, increased filling volumes dilate the heart, thereby increasing actin-myosin cross-bridge formation and enhancing contractility and stroke volume. Activation of neurohumoral systems. These augment heart function and / or regulate filling volumes and pressures. Release of norepinephrine by adrenergic nerves of the autonomic nervous system, elevating heart rate, augmenting myocardial contractility and increasing vascular resistance. Activation of the renin-angiotensin-aldosterone system, promoting water and salt retention and increasing vascular tone. Release of atrial natriuretic peptide, counterbalancing the renin-angiotensin-aldosterone system through diuresis and vascular smooth muscle relaxation. Myocardial adaptations. In many pathologic states, heart failure is preceded by cardiac hypertrophy, a compensatory response to increased mechanical work. Ventricular remodeling is the general term applied to the collective molecular, cellular, and structural changes that occur in response to injury or altered ventricular loading. Although such adaptive mechanisms can potentially maintain adequate cardiac output in the face of acute perturbations, their capacity to do so may ultimately be overwhelmed. Heart failure can result from progressive deterioration of myocardial contractile function, reflected as a decrease in ejection fraction. Reduction in EF can occur with ischemic injury, inadequate adaptation to pressure or volume overload due to hypertension or valvular disease, or ventricular dilation. Increasingly, heart failure is recognized as resulting from an inability of the heart chamber to expand and fill sufficiently during diastole, for example, due to left ventricular hypertrophy, myocardial fibrosis, constrictive pericarditis, or amyloid deposition. Cardiac hypertrophy, pathophysiology and progression to heart failure. Sustained increase in mechanical work of either ventricle due to pressure overload, volume overload, or trophic signals causes myocytes to increase in size. Cumulatively, this increases the size and weight of the heart. Hypertrophy requires increased protein synthesis to form additional sarcomeres, as well as increasing the numbers of mitochondria. Hypertrophic myocytes also have multiple or enlarged nuclei, attributable to increased DNA ploidy resulting from DNA replication in the absence of cell division. The pattern of hypertrophy reflects the nature of the stimulus. In pressure overload hypertrophy, new sarcomeres are predominantly assembled in parallel to the long axis of cells, expanding the cross-sectional area of myocytes and ventricles and causing a concentric increase in wall thickness. In contrast, volume overload hypertrophy is characterized by new sarcomeres being assembled in series within existing sarcomeres, leading primarily to ventricular dilation. As a result, in dilation due to volume overload, or dilation that accompanies failure of a previously pressure-overloaded heart, the wall thickness may be increased, normal, or less than normal. Consequently, heart weight, rather than wall thickness, is the best measure of hypertrophy in dilated hearts. Heart disease can lead to dramatic levels of cardiac hypertrophy. Patients with systemic hypertension, aortic stenosis, mitral regurgitation, or dilated cardiomyopathy frequently have heart weights double or triple the average. And aortic regurgitation or hypertrophic cardiomyopathy can produce heart weights 3-fold to 4-fold greater than normal. Important changes at the tissue and cell level occur with cardiac hypertrophy. Significantly, myocyte hypertrophy, a B. CD figure 12.1 left ventricular hypertrophy. Pressure hypertrophy due to left ventricular outflow obstruction. The left ventricle is on the lower right in this apical four-chamber view of the heart. Left ventricular hypertrophy with and without dilation, viewed in transverse heart sections. Compared with a normal heart, the pressure hypertrophied hearts have increased mass in the thick left ventricular wall, and the hypertrophied, dilated heart has increased mass in an apparently normal wall thickness. Normal myocardium. Hypertrophied myocardium. Note the increases in both cell size and nuclear size in the hypertrophied myocytes, and the interstitial cells remain small. It is not accompanied by a proportional increase in capillary numbers. As a result, the supply of oxygen and nutrients to the hypertrophied heart, particularly one undergoing pressure overload hypertrophy, is more tenuous than in the normal heart. At the same time, cardiac hypertrophy is associated with heightened metabolic demands due to increases in mass, heart rate, and contractility, all of which increase cardiac oxygen consumption. As a result of these changes, the hypertrophied heart is vulnerable to ischemia-related decompensation, which can evolve to cardiac failure. Adding insult to injury, hypertrophy is also typically accompanied by deposition of fibrous tissue, causing increased resistance to diastolic filling. Molecular changes in hypertrophy cardiomyocytes include the expression of immediate early genes putatively driving cellular growth and altered protein expression. With prolonged hemodynamic overload, myocytes can even express genes usually only seen during fetal cardiac development. The proposed sequence of initially adaptive and later harmful events in response to increased cardiac work is summarized in Fig. 12.2. As illustrated, heart failure eventually supervenes. The degree of anatomic abnormality does not always reflect the severity of dysfunction. Indeed, The gross appearance of the failing heart does not adequately convey the underlying structural, biochemical, and molecular basis for myocardial contractile failure. The hearts of patients with CHF are generally heavy and dilated, but can be relatively thin-walled, and histologically they exhibit variable degrees of myocyte hypertrophy. Loss of myocardial mass in the setting of infarction leads to work-related hypertrophy of the surrounding viable myocardium. In valvular heart disease, the increased pressure or volume overloads the myocardium globally. Increased heart mass owing to disease, hypertension, pressure overload, valvular disease, pressure and or volume overload, cardiac work, wall stress, cell stretch, hypertrophy and or dilation, characterized by heart size and mass, protein synthesis, induction of immediate early genes, induction of fetal gene program, abnormal proteins, fibrosis, inadequate vasculature, cardiac dysfunction, characterized by heart failure, arrhythmias, neurohumoral stimulation. Figure 12.2 schematic representation of the causes and consequences of cardiac hypertrophy is correlated with excess cardiac mortality and morbidity. Indeed, cardiomegaly is an independent risk factor for sudden death. In contrast to the pathologic hypertrophy associated with persistent mechanical stressors, regular exercise can promote potentially beneficial physiologic hypertrophy. Aerobic exercise tends to be associated with volume load hypertrophy accompanied by increases in capillary density. Regular aerobic activity also decreases the resting heart rate and blood pressure, effects that are all beneficial. In comparison, purely static exercise induces mild pressure hypertrophy and less beneficial remodeling. Whatever its basis, CHF is characterized by variable degrees of decreased cardiac output and tissue perfusion, as well as pooling of blood in the venous capacitance system. The latter may cause pulmonary edema, peripheral edema, or both. As a result, many of the significant clinical features and morphologic changes noted in CHF are actually secondary to disorders induced by hypoxia and congestion in non-cardiac peripheral tissues. The cardiovascular system is a closed circuit. Thus, although left-sided and right-sided failure can occur independently, failure of one side often produces excessive strain on the other, terminating in global heart failure. Despite this interdependence, it is easiest to understand the pathology of heart failure by considering right and left-sided heart failure separately. Myocardial infarction, regional dysfunction with volume overload, left-sided heart failure. Left-sided heart failure is most often caused by the following. Hypertension, aortic and mitral valvular diseases, primary myocardial diseases. The clinical and morphologic effects of left-sided CHF are a consequence of passive congestion, stasis of blood in the left-sided chambers, and inadequate perfusion of downstream tissues leading to organ dysfunction. Morphology heart. The findings depend on the disease process, ranging from myocardial infarcts to stenotic or regurgitant valves to intrinsic myocardial pathology. Except for failure caused by mitral valve stenosis or unusual restrictive cardiomyopathies, the left ventricle is usually hypertrophied and often dilated, sometimes massively. Left ventricular diastolic dysfunction or dilation with mitral valve incompetence causes secondary dilation of the left atrium, increasing the risk of atrial fibrillation. This in turn results in stasis of blood, particularly in the atrial appendage, which is a common site of thrombus formation. The microscopic changes in the failing heart are nonspecific, variable degrees of myocyte hypertrophy and interstitial fibrosis. Lungs, pulmonary congestion and edema produce heavy, wet lungs, as described elsewhere. Pulmonary changes, from mildest to most severe, include perivascular and interstitial edema, particularly in the interlobular septum, progressive edematous widening of alveolar septum, and accumulation of edema fluid in the alveolar spaces. Extravasated red cells and plasma proteins in the alveoli are phagocytosed and digested by macrophages. The accumulated iron is stored as hemosiderin. These hemosiderin-laden macrophages are telltale signs of previous episodes of pulmonary edema. Pleural effusions arise from elevated pleural capillary and lymphatic pressure and the resultant transudation of fluid into the pleural cavities. Early left-sided heart failure symptoms are related to pulmonary congestion and edema. Initially, cough and dyspnea may occur only with exertion. As CHF progresses, worsening pulmonary edema may cause orthopnea or paroxysmal nocturnal dyspnea. Dyspnea at rest may follow. The respiratory symptoms are characteristically associated with fine rales at the lung bases, caused when edematous pulmonary alveoli snap open during inspiration. Other manifestations of left ventricular failure include an enlarged heart, tachycardia, a third heart sound due to volume overload, or a fourth heart sound due to increased myocardial stiffness. If heart failure is associated with progressive ventricular dilation, the papillary muscles are displaced outward, causing mitral regurgitation. Subsequent chronic dilation of the left atrium can cause atrial fibrillation, and such uncoordinated, chaotic atrial contractions reduce the atrial contribution to ventricular filling, thus reducing the ventricular stroke volume. In moderate CHF, A reduced ejection fraction leads to diminished renal perfusion, causing activation of the renin-angiotensin-aldosterone system as a compensatory mechanism to correct the perceived hypotension. This leads to salt and water retention, with expansion of the interstitial and intravascular fluid volumes exacerbating the ongoing pulmonary edema. If the hypoperfusion of the kidney becomes sufficiently severe, impaired excretion of nitrogenous products may cause azotemia. And for advanced CHF, cerebral hypoperfusion can give rise to hypoxic encephalopathy, with irritability, loss of attention span, and restlessness that can progress to stupor and coma with ischemic cerebral injury. Left-sided heart failure can be divided into systolic and diastolic failure. Systolic failure is defined by insufficient ejection fraction and can be caused by any of the many disorders that damage or derange the contractile function of the left ventricle. In diastolic failure, the left ventricle is abnormally stiff and cannot relax during diastole. Thus, although cardiac function is relatively preserved at rest, the heart is unable to increase its output in response to increases in the metabolic demands of peripheral tissues. Moreover, because the left ventricle cannot expand normally, any increase in filling pressure is immediately transferred back into the pulmonary circulation, producing pulmonary edema. Hypertension is the most common underlying etiology. Diabetes mellitus, obesity, and bilateral renal artery stenosis can also be causal. Reduced left ventricular relaxation may stem from myocardial fibrosis or infiltrative disorders associated with restrictive cardiomyopathies. Diastolic failure may appear in older patients without any known predisposing factors, possibly as an exaggeration of the normal stiffening of the heart with age. Constricted pericarditis can also limit myocardial relaxation and therefore mimics primary diastolic dysfunction. Right-sided heart failure. Right-sided heart failure is most commonly caused by left-sided heart failure, as any increase in pressure in the pulmonary circulation from left-sided failure inevitably burdens the right side of the heart. Consequently, the causes of right-sided heart failure include all the etiologies for left-sided heart failure. Isolated right-sided heart failure is infrequent and typically occurs in patients with one of a variety of disorders affecting the lungs, hence it is often referred to as cor pulmonale. Besides parenchymal lung diseases, cor pulmonale can also arise secondary to disorders that affect the pulmonary vasculature, for example, primary pulmonary hypertension, recurrent pulmonary thromboembolism, or conditions that cause pulmonary vasoconstriction. The common feature of these disorders is pulmonary hypertension, which results in hypertrophy and dilation of the right side of the heart. In extreme cases, leftward bulging of the interventricular septum can even cause left ventricular dysfunction. The major morphologic and clinical effects of primary right-sided heart failure differ from those of left-sided heart failure in that pulmonary congestion is minimal while engorgement of the systemic and portal venous systems is pronounced. Morphology heart. As in left heart failure, the cardiac morphology varies with cause. Rarely, structural defects such as tricuspid or pulmonary valvular abnormalities or endocardial fibrosis may be present. However, because isolated right heart failure is most often caused by lung disease, most cases exhibit only hypertrophy and dilation of the right atrium and ventricle. Liver and portal system. Congestion of the hepatic and portal vessels may produce pathologic changes in the liver, the spleen, and the gastrointestinal tract. The liver is usually increased in size and weight caused by passive congestion, greatest around the central veins chapter. 4. Grossly, this is reflected as congested red-brown paracentral zones with relatively normal color tan periportal regions, producing the characteristic nutmeg liver appearance. In some instances, especially when left-sided heart failure with hypoperfusion is also present, severe centrilobular hypoxia produces centrilobular necrosis. With long-standing severe right-sided heart failure, the central areas can become fibrotic, eventually culminating in cardiac cirrhosis. Portal venous hypertension also causes enlargement of the spleen with platelet sequestration and can also contribute to chronic congestion and edema of the bowel wall. The latter may be sufficiently severe as to interfere with nutrient absorption. Pleural, pericardial, and peritoneal spaces. Systemic venous congestion can lead to fluid accumulation in the pleural, pericardial, or peritoneal spaces of peritoneal effusionists, also called ascites. Large pleural effusions can impact lung inflation, causing atelectasis, and substantial ascites can also limit diaphragmatic excursion, causing dyspnea on a purely mechanical basis. Subcutaneous tissues. Edema of the peripheral and dependent portions of the body, especially foot/ankle and pertibial. Edema is a hallmark of right-sided heart failure. In chronically bedridden patients, prosacral edema may predominate. Generalized, massive edema can also occur. The kidney and the brain are also prominently affected in right-sided heart failure. Renal congestion is more marked with right-sided than with left-sided heart failure, leading to greater fluid retention and peripheral edema, and more pronounced azotemia. Venous congestion and hypoxia of the central nervous system can also produce deficits of mental function akin to those seen in left-sided heart failure with poor systemic perfusion. Although we have discussed right and left heart failure separately, it is again worth emphasizing that in many cases of chronic cardiac decompensation, patients with biventricular CHF have symptoms reflecting both right-sided and left-sided heart failure. Besides a careful history and physical examination, serum levels of B-type natriuretic factor have become a popular tool to quantitatively assess the extent of CHF. Recall that BNP is released by ventricular cardiomyocytes during increased wall stress. A low value has a high negative predictive value for CHF. Echocardiography is also an extremely valuable tool in following patients with CHF, providing a measure of ejection fraction, wall motion, valvular function, and possible mural thrombosis. Treatment for CHF is initially focused on correcting any underlying cause, for example, a valvular defect or inadequate cardiac perfusion. Beyond that, the clinical approach includes salt restriction or pharmacologic agents that variously reduce volume overload, increase myocardial contractility, or reduce afterload. Although many of these medications provide benefit through effects on neurohumoral pathways, AC inhibitors also limit myocyte hypertrophy and cardiac remodeling. Although cardiac resynchronization therapy and mechanical ventricular assist devices have also been added to the cardiologist's armamentarium, CHF remains a serious cause of human morbidity and mortality. Key concepts: heart failure. Heart failure occurs when the heart is unable to provide adequate perfusion to meet the metabolic requirements of peripheral tissues. Inadequate cardiac output is usually accompanied by increased congestion of the venous circulation. Left-sided heart failure is most commonly due to IHD, systemic hypertension, mitral or aortic valve disease, and primary diseases of the myocardium. Symptoms are mainly a consequence of pulmonary congestion and edema, although systemic hypoperfusion can cause secondary renal and cerebral dysfunction. Right-sided heart failure is most often due to left heart failure, and less commonly to primary pulmonary disorders. Symptoms are chiefly related to peripheral edema and visceral congestion. Cardiac development. The heart is a mechanical organ that generates pulsatile blood within just 3 weeks after fertilization. It is therefore likely that hemodynamic forces play an important role in cardiac development, just as they influence adaptations in the adult heart such as hypertrophy and dilation. The diverse malformations seen in congenital heart disease are caused by errors that occur during the complex migration and folding that constitutes cardiac morphogenesis. Derived from cells in the lateral mesoderm, the earliest cardiac precursors move to the midline in 2 migratory waves within the first 15 days of fetal development. Although these are multipotent progenitor cells that can produce all of the major cell types of the heart, they rapidly assume distinct fates. Cells in the first wave largely populate the developing left ventricle, whereas those in the second wave become the outflow tract, right ventricle, and most of the atria. Thus, defects in one or the other anlage can explain some of the CHEs involving discrete structures. By day 20 of development, the nascent heart has become a beating tube, which begins to form the basic heart chambers roughly 8 days later. At about the same time, neural crest derived cells migrate into the outflow tract, where they participate in the septation of the aortic and pulmonic outflow tracts and the formation of the aortic arch. And interstitial connective tissue expands to become definitive endocardial cushions that will become the future atrioventricular canals and outflow tracts. By day 50, further septation of the ventricles, atria, and atrioventricular valves produces a 4-chambered heart. Proper orchestration of these remarkable transformations depends on a network of transcription factors that are regulated by a number of signaling pathways, particularly the W&T, hedgehog, vascular endothelial growth factor, or morphogenetic protein, transforming growth factor beta, fibroblast growth factor, and Notch pathways. It is not too surprising then that many of the inherited defects that affect heart development involve genes that encode transcription factors. These typically cause partial loss of function and are autosomal dominant. In addition, specific microRNAs play critical roles in cardiac development by coordinating patterns and levels of transcription factor expression. Congenital heart disease. CHE refers to abnormalities of the heart or great vessels that are present at birth. Most CHE arises from faulty embryogenesis during gestational weeks 3 to 8, when major cardiovascular structures form and begin to function. The most severe anomalies preclude intrauterine survival, and significant heart malformations are common among stillborn infants. On the other hand, circumscribed defects affecting discrete regions of the heart or individual chambers can be compatible with live birth. In this latter category are the following: septal defects, or holes in the heart, including atrial septal defects or ventricular septal defects. Stenotic lesions, either at the level of valves or the entire cardiac chamber, as in hypoplastic left heart syndrome. Outflow tract anomalies, including inappropriate routing of the great vessels from the ventricles or anomalous coronary arteries. Such tolerated forms of CHE usually produce clinically important manifestations only after birth. Uncovered by the transition from fetal to perinatal circulation, roughly one-half will be diagnosed in the first year of life, although some milder forms may not be discovered until adulthood. The incidence of CHE depends on what is counted as a defect. Thus, if echocardiography is performed routinely on neonates, small muscular VSDs or ASDs are detected in over 5% of live births. However, these typically close. Table 12.2 Frequencies of congenital cardiac malformations. Incidence per malformation million live births percent. Ventricular septal defect 4482.42. Atrial septal defect 1043.10. Pulmonary stenosis 836.8. Patent ductus arteriosus 781.7. Tetralogy of fallout 577.5. Portation of the aorta 492.5. Atrioventricular septal defect 396.4. Aortic stenosis 388.4. Transposition of the great arteries 388.4. Truncus arteriosus 136.1. Total anomalous pulmonary 121. Venous connection. Tricuspid atresia 118.1. Total 9,757, are presented as upper quartile of 44 published studies. Percentages do not add up to 100% because of rounding. Does not include bicuspid aortic valves. Data from Hoffman J.I., Kaplan S., The Incidence of Congenital Heart Disease, J. and Cardio 39, 1890, 190, 2002. Syndrome. Indeed, the most common known genetic cause of CHE is trisomy 21. Roughly 40% of patients with Down syndrome have one or more heart defects, most often affecting structures derived from the second migratory wave of cells. The mechanisms by which aneuploidy causes CHE likely involve the dysregulated expression of multiple genes. A notable example of a small chromosomal lesion causing CHE is deletion of chromosome 20 twice, occurring in patients with DiGeorge syndrome. In this syndrome, the fourth branchial arch and the derivatives of the third and fourth pharyngeal pouches develop abnormally. Of the 30 or so genes present on this chromosome segment, deletion of the TB zone transcription factor gene is probably the culprit lesion. TB zone regulates neural crest migration, as well as the expansion of cardiac progenitors in the second migratory wave. Interestingly, deletions in this region are also associated with mental illness, including schizophrenia. In the case of single gene mutations, the affected genes encode proteins belonging to several different functional classes. As mentioned earlier, many of these involve transcription factors. Because affected patients are heterozygous for such mutations, it follows that a 50% reduction in the activity of these factors may spontaneously in the first year of life, and they probably should not be tallied with the burden of CHD. Similarly, bicuspid aortic valve, with an incidence of 1% to 2%, clearly persists beyond infancy, but often has modest manifestations and may not become evident until late adulthood. If their counting is restricted to more serious defects, the worldwide incidence of congenital cardiovascular malformations is slightly less than 1%, still ranking CHE among the most prevalent birth defects. 12 disorders account for about 85% of cases. Their frequencies are listed in Table 12.2. The number of individuals who survive into adulthood with CHE is increasing rapidly and is estimated at nearly 1.5 million people in the United States alone. Many have benefited from surgical advances that increasingly permit early postnatal repair of structural defects. In some cases, however, surgical intervention fails to restore complete normalcy. Patients may have already sustained pulmonary or myocardial changes that are no longer reversible, or conversely, may suffer from arrhythmias due to surgical scarring. Other factors that impact the long-term outcome include complications associated with the use of prosthetic materials and devices, and the cardiovascular stressors associated with childbearing that may tip a repaired heart into failure. Table 12.3 Selected examples of gene defects associated with congenital heart disease. Gene product, disorder gene function, non-syndromic, ASD or conduction defects 2.5. Transcription factor, ASD or VSD GATFR transcription factor. Tetralogy of fallout CFB mTOR or transcription factors. 2.5. Syndromic, Alago syndrome, JAGON or signaling proteins or pulmonary artery stenosis not atrial receptors or tetralogy of fallout. Charge syndrome, PDA TFA P12B transcription factor. Charge syndrome, as CHD7 helicase binding VSD, PDA, or hypoplastic protein right side of the heart. DiGeorge syndrome, as TB zone transcription factor VSD, or outflow tract obstruction. Whole arm syndrome, as TBX5 transcription factor VSD, or conduction defect. Milner syndrome, PTP-11, signaling proteins, pulmonary valve stenosis, HRAS, VSD, or hypertrophic susome cardiomyopathy, as atrial septal defect, Charge, posterior collarboma, heart defect, choanal atresia, retardation, genital and ear anomalies, PDA, panductus arteriosus, VSD, ventricular septal defect. Different mutations can cause the same phenotype, and mutations in some genes can cause multiple phenotypes. Many of these congenital lesions also can occur sporadically, without specific genetic mutation. Only the cardiac manifestations of the syndrome are listed. The other skeletal, facial, neurologic, and visceral changes are not. Etiology and pathogenesis, environmental exposures, and genetic factors are the best characterized causes but still account for a minority of CHE cases. Nutritional factors can also influence risk. Folate supplementation during early pregnancy reduces CHE incidence. Genetic factors include specific loci implicated in familial forms of CHE and certain chromosomal abnormalities, for example, trisomies 13, 15, 18, and 21, and monosomy X/Turner. Is sufficient to derange cardiac development. Even relatively minor decrements in activity of particular genes can result in significant defects. Thus, transient environmental stresses during the first trimester of pregnancy that alter the synthesis or activity of these same genes can conceivably lead to acquired defects that mimic those produced by heritable mutations. In addition, many of the transcription factors interact in large protein complexes, providing a rationale for why mutations in any one of several genes can produce similar defects. Thus, JTFR, TBX5, and AKXO5, three transcription factors that are mutated in some patients with atrial and ventricular septal defects, all bind to one another and co-regulate the expression of target genes required for proper cardiac development. Other single gene mutations can alter structural proteins or affect signaling pathway molecules. Thus, mutations in genes encoding various components of the Notch pathway are associated with a variety of congenital heart defects, including bicuspid aortic valve and tetralogy of Fallot. As described in Chapter 5 and 11, fibrillin mutations underlie Marfan syndrome, associated with valvular defects and aortic aneurysms. Although fibrillin is an important structural protein in the extracellular matrix, it is also an important negative regulator of TGF-beta signaling, and hyperactive TGF-beta signaling contributes to the cardiovascular abnormalities in Marfan syndrome and the related Loeys-Dietz syndrome. Despite these advances, our understanding of the mechanisms underlying CHE remains rudimentary. The precise cause is unknown in almost 90% of cases. Most affected patients have no identifiable genetic risk, and even in those that do, the nature and severity of the defect are highly variable. It is likely that most forms of CHE arise by interactions of environmental factors with multiple genes. Guidelines for genetic testing are complex and evolving but suggest that genetic testing may be useful in patients with a broader non-cardiac syndrome or a family history of CHE. Clinical features. Most of the various structural anomalies in CHE can be organized into three major categories according to the major functional abnormalities they cause. Left to right shunt, right to left shunt, obstruction. A shunt is an abnormal communication between chambers or blood vessels. Abnormal channels permit blood flow down pressure gradients from the left side to the right side of the circulation or vice versa. When blood from the right side of the circulation flows directly into the left side, hypoxemia and cyanosis result because the pulmonary circulation is bypassed and poorly oxygenated venous blood shunts directly into the systemic arterial supply. In addition, right to left shunts can allow emboli from the peripheral veins to bypass the lungs and directly enter the systemic circulation. Severe, long-standing hypoxia/cyanosis also causes increased numbers of circulating red blood cells, as well as a peculiar distal blunting and enlargement of the tips of the fingers and toes that can include bony changes. The most important causes of right to left shunts are tetralogy of Fallot, transposition of the great arteries, persistent truncus arteriosus, tricuspid atresia, and total anomalous pulmonary venous connection. In contrast, left to right shunts increase pulmonary blood flow but are not initially associated with cyanosis. However, left to right shunts chronically elevate both volume and pressure in the normally low pressure, low resistance pulmonary circulation. To maintain relatively normal distal pulmonary capillary and venous pressures, the muscular pulmonary arteries initially respond by undergoing medial hypertrophy and vasoconstriction. However, prolonged pulmonary arterial vasoconstriction stimulates the development of irreversible obstructive intimal lesions analogous to the arteriolar changes seen in systemic hypertension. Pulmonary arteries can even develop frank atherosclerotic lesions. The right ventricle also responds to the pulmonary vascular changes by undergoing progressive hypertrophy. Eventually, pulmonary vascular resistance approaches systemic levels, and the original left to right shunt becomes a right to left shunt that introduces poorly oxygenated blood into the systemic circulation. Once irreversible pulmonary hypertension develops, the structural defects of CHE are considered irreparable. Subsequent right heart failure can lead to the patient's death unless combined heart-lung transplantation can be performed. This provides the rationale for early intervention to close significant left to right shunts. Obstructive CHD occurs when there is abnormal narrowing of chambers, valves, or blood vessels. These include coarctation of the aorta, aortic valvular stenosis, and pulmonary valvular stenosis. A complete obstruction is called an atresia. In some disorders, an obstruction and a shunt are both present. The altered hemodynamics of CHD usually cause cardiac dilation or hypertrophy. However, some defects induce a decrease in the volume and muscle mass of the cardiac chamber. This is called hypoplasia if it occurs before birth and atrophy if it develops postnatally. Left to right shunts. Left to right shunts are the most common CHD. These include ASD, VSD, and PDA. ASDs typically increase only right ventricular and pulmonary outflow volumes, and VSDs and PDA cause both increased pulmonary blood flow and pressure. Depending on their size and location, manifestations of these shunts range in severity from no symptoms at all to fulminant heart failure. Atrial septal defect ASDs are abnormal, fixed openings in the atrial septum caused by incomplete tissue formation that allows communication of blood between the left and right atria. ASDs are usually asymptomatic until adulthood. ASD should not be confused with patent foramen ovale, which represents the postnatal, RA, LA, RV, LPT, LA, LV, atria. The valve opens only when the pressure is greater in the right atrium. In fetal life, the lungs are non-functional, and the pressure in the pulmonary circulation is greater than that of the systemic circulation. Thus, the right atrium is under higher pressures than the left atrium, and the valve of the foramen ovale is normally open. At birth, with lung expansion, the pulmonary vascular pressures drop, and the right atrial pressures fall below those in the left atrium. As a result, the valve of the foramen ovale closes, and is usually permanently sealed before adulthood. B. RA, RV, LPT. VSD, a figure 12.3 common congenital left to right shunts. Atrial septal defect, ventricular septal defect. With VSD, the shunt is left to right, and the pressures are the same in both ventricles. Pressure hypertrophy of the right ventricle and volume hypertrophy of the left ventricle are generally present. Patent ductus arteriosus, aorta, LA, left atrium, LV, left ventricle, PT, pulmonary trunk, RA, right atrium, RV, right ventricle. Failure to close a foramen that is part of normal development. A brief summary of the developmental stages of the atrial septum follows. The septum primum is a crescent-shaped membranous ingrowth that sits posteriorly between the right and left atria and partially separates them. The remaining transient anterior opening, called the ostium primum, allows movement of blood from the right to left atrium during early fetal development. Before the growing septum primum completely obliterates the ostium primum, it develops a second posterior opening called the ostium secundum. The septum secundum is a subsequent membranous ingrowth located to the right and anterior of the septum primum. The septum secundum grows to cover the ostium secundum, leaving only a small channel called the foramen ovale that is continuous with the ostium secundum. The foramen ovale/ostium secundum permits continued right to left shunting of blood during intrauterine development. This flap of septum secundum tissue opens and closes in response to pressure gradients between the left and right. LA, LV as RA, RV, PT, PDA, LA, LV. Morphology ASDs are classified according to their location. Secundum ASD result from a deficient septum secundum formation near the center of the atrial septum. These are usually not associated with other anomalies, may be of any size, and can be multiple or fenestrated. Primum anomalies occur adjacent to the AV valves and are often associated with AV valve abnormalities and /or VSD. Sinus venosus defects are located near the entrance of the superior vena cava and can be associated with anomalous pulmonary venous return to the right atrium. Clinical features ASDs are usually asymptomatic until adulthood. Although VSDs are more common, most close spontaneously. Consequently, which are less likely to close spontaneously, are the most common defects to be diagnosed in adults. ASDs result in a left to right shunt, largely because pulmonary vascular resistance is considerably less than systemic vascular resistance and because the compliance of the right ventricle is much greater than that of the left. The resulting pulmonary flow volumes may be 2 to 8 times normal. A murmur is often present as a result of excessive flow through the pulmonary valve and / or through the ASD. Despite the right-sided volume overload, ASDs are generally well tolerated and usually do not become symptomatic before 30 years of age. Irreversible pulmonary hypertension is unusual. Surgical or intravascular ASD closure is performed to preempt the development of heart failure, paradoxical embolization, and irreversible pulmonary vascular disease. Mortality is low, and postoperative survival is comparable to that for an unaffected population. Patent foramen ovale. The foramen ovale closes permanently in approximately 80% of people by 2 years of age. However, in the remaining 20%, the unsealed flap can open if right-sided pressures become elevated. Thus, sustained pulmonary hypertension or even transient increases in right-sided pressures can produce brief periods of right-to-left shunting, with the possibility of paradoxical embolism. Ventricular septal defect. VSDs are incomplete closures of the ventricular septum, allowing free communication of blood between the left or right ventricles. They are the most common form of CHD. Figure 12.4. A membranous type ventricular septal defect just proximal to the aortic valve. Morphology. VSDs are classified according to their location and magnitude. About 90% occur in the region of the membranous interventricular septum, and the majority are 2 to 3 cm in diameter. The remaining 10% occur below the pulmonary valve or within the muscular septum. Although most VSDs are single, those in the muscular septum may be multiple. The pulmonary artery to the aorta, thereby bypassing the unoxygenated lungs. In healthy-term infants, the ductus constricts and is functionally closed within 1 to 2 days of birth. This occurs in response to increased arterial oxygenation, decreased pulmonary vascular resistance, and declining local levels of prostaglandin A1. Complete structural obliteration occurs within the first few months of extrauterine life, leaving behind the ligamentum arterius. Ductal closure is often delayed in infants with hypoxia or when other congenital defects are present, particularly VSDs that increase pulmonary vascular pressures. PDAs account for about 7% of cases of CHD, and 90% of these are isolated defects. PDA produces a characteristic, continuous, harsh machinery-like murmur. The clinical impact of a PDA depends on its diameter and the cardiovascular status of the individual. PDA is usually asymptomatic at birth, and a narrow PDA may have no effect on the child's growth and development. Because the shunt is initially left to right, there is no cyanosis. However, with large shunts, the additional volume and pressure overloads eventually produce obstructive changes in small pulmonary arteries, leading to reversal of flow and its associated consequences. In general, isolated PDA should be closed as early in life as is feasible. Therapy includes prostaglandin synthesis inhibitors and possibly percutaneous or surgical interventions. Conversely, preservation of ductal patency may be life-saving for infants with various congenital malformations that obstruct the pulmonary or systemic outflow tracts. In CHD with aortic valve or pulmonary valve atresia, for example, a PDA may provide the entire systemic blood flow or pulmonary blood flow, respectively. Clinical features. Right to left shunts. Most VSDs that clinically manifest in the pediatric age group are associated with other congenital cardiac anomalies. Such the diseases in this group cause cyanosis early and postnatal as TOF. Only 20% to 30% are isolated. Conversely, if a VSD life, TOF, the most common in this group, is first detected only in an adult, it is usually an isolated and TGA are illustrated schematically in Fig. 12.5. The others defect. The functional consequences of a VSD depend on include persistent truncus arteriasis, tricuspid atresia, and the size of the defect and whether there are associated total anomalous pulmonary venous connection. Note that right-sided malformations, thus large VSDs, cause difficulties. The names of all of these conditions start with a T, virtually from birth. Smaller lesions are generally well tolerated for years and may not be recognized until much later in life. Moreover, approximately 50% of small muscular. The 4 cardinal features of TOF are VSD. Obstruction. VSDs close spontaneously. Large defects are usually of the right ventricular outflow tract, branus or infundibular, and they generally cause significant an aorta that overrides the VSD, and right ventricular left to right shunting, leading to early right ventricular hypertrophy. The first 3 features result hypertrophy and pulmonary hypertension. Over time, large embryologically from anterior superior displacement of the unclosed VSDs almost universally lead to irreversible infundibular septum and the right ventricular hypertrophy, pulmonary vascular disease, ultimately resulting in shunt as a secondary consequence of the pressure overload. Reversal and cyanosis. Surgical or catheter-based closure of asymptomatic VSD is generally delayed beyond infancy in hope of spontaneous closure. Early correction, however, must be performed for large defects to prevent the development. The heart is typically enlarged and is classically boot-shaped, meant of irreversible obstructive pulmonary vascular disease. Due to marked right ventricular hypertrophy, the VSD is usually patent ductus arteriasis. The ductus arteriasis arises from the pulmonary artery and joins the aorta just distal to the origin of the left subclavian artery. During intrauterine life, it permits blood flow from RA or VA PT Ra ALA with VSD, B RVI, PT, classic tetralogy of Fallot, Ra, LV complete transposition. Figure 12.5 common congenital right to left shunts, tetralogy of Fallot. The direction of shunting across the ventricular septal defect depends on the degree of the subpulmonic stenosis. One severe or right to left shunt results. Dexter transposition of the great arteries with and without VSD. Al, aorta, LA, left atrium, LV, left ventricle, PT, pulmonary trunk, Ra, right atrium, RV, right ventricle. LA, LV out RV, without VSD. PT, LA, LV, and thinner walled and the larger is the overriding aorta. As the child grows and the heart increases in size, the pulmonic orifice does not expand proportionally, making the obstruction progressively worse. The subpulmonic stenosis, however, protects the pulmonary vasculature from pressure overload, and right ventricular failure is rare because the right ventricle is decompressed by the shunting of blood into the left ventricle and aorta. Complete surgical repair is possible but becomes complicated for individuals with pulmonary atresia and dilated bronchial arteries. Transposition of the great arteries TGA produces ventricular arterial discordance. In the more common variant, the aorta rises from the right ventricle, and the pulmonary artery emanates from the left ventricle. The atrium to ventricle connections are normal, with the right atrium joining the right ventricle and the left atrium emptying into the left ventricle. The embryologic defect in complete TGA stems from abnormal formation of the spiraling truncal and aortopulmonary septi. The result is separation of the systemic and pulmonary circulations, a condition incompatible with postnatal life unless a shunt exists for adequate mixing of blood. The outlook for infants with DTGA depends on the degree of blood mixing, the magnitude of tissue hypoxia, and the ability of the right ventricle to maintain the systemic circulation. Patients with DTGA and a VSD often have a stable shunt. However, dependence on a patent foramen ovale or ductus arteriasis for blood mixing is problematic. These systemic top pulmonary connections tend to close early and thus require intervention to create a new shunt within the first few days of life. With time, right? By pulmonary valvular stenosis. Sometimes there is complete atresia of the pulmonary valve in variable portions of the pulmonary arteries, such that blood flow through a PDA, dilated bronchial arteries, or both, is necessary for survival. Aortic valve insufficiency or an ASD may also be present. A right aortic arch is present in about 25% of cases. Clinical features depending on the severity of the subpulmonic stenosis. Untreated TOF can be tolerated into adulthood. 10% of unoperated individuals are alive at 20 years of age, and 3% survive for 40 years. If the subpulmonic stenosis is mild, the abnormality resembles an isolated VSD, and the shunt may be left or right, without cyanosis. With more severe right ventricular outflow obstruction, right-sided pressures approach or exceed left-sided pressures, and right-to-left shunting develops, producing cyanosis. Most infants with TOF are cyanotic at birth or soon thereafter. The more severe the subpulmonic stenosis, the more hypoplastic are the pulmonary arteries. Ra, aorta, pulmonary, trunk, LV, LA, RV. Congenital obstruction to blood flow can occur at the level of the heart valves or within a great vessel. Common examples include aortic or pulmonary valve stenosis or atresia, and coarctation of the aorta. Obstruction can also occur within a chamber, as with subpulmonic stenosis and TOF. Coarctation of the aorta ranks high in frequency among the common structural anomalies. It is twice as common in males as in females. Interestingly, females with Turner syndrome are also frequently affected. There are two classic forms: an infantile form, often symptomatic in early childhood, with tubular hypoplasia of the aortic arch proximal to a PDA, and an adult form with a discrete ridge-like enfolding of the aorta just opposite the closed ductus arteriasis distal to the arch vessels. Encroachment, figure 12.7 schematic for congenitally corrected levotransposition of the great arteries. The right atrium flows to the morphologic left ventricle, which connects to the pulmonary arteries. The left atrium connects to the morphologic right ventricle, which empties into the aorta, which is anomalously anterior and to the left. This congenital malformation may be well tolerated, presenting only relatively late in adulthood with decompensation of the morphologic right ventricle. Ra, LPT, LA, Ra, LPT, LA. Ventricular hypertrophy becomes prominent because this chamber is functioning as the systemic ventricle. Concurrently, the left ventricle becomes thin-walled as it supports the low-resistance pulmonary circulation. Without surgery, most patients die within months. However, improved early surgical intervention, typically with an arterial switch operation, allows many patients with DTGA to survive into adulthood. In the less common levo TGA, the right atrium connects to a ventricle with the internal morphology of a left ventricle, which in turn empties into the pulmonary arteries. At the same time, the left atrium connects to a morphologic right ventricle, which empties into the aorta. LTGA does not lead to cyanosis and indeed can be entirely asymptomatic, being diagnosed in adulthood only during a workup for other cardiac issues. Nevertheless, LTGA will result in hypertrophy of the morphologic right ventricle and eventually can cause heart failure. It is also often associated with other CHEs such as VSD, as in panforamen ovale. Tricuspid atresia. Tricuspid atresia represents complete occlusion of the tricuspid valve orifice. It results embryologically from unequal division of the AV canal. Thus, the mitral valve is larger than normal, and there is right ventricular underdevelopment. The circulation can be maintained by right or left shunting through an interatrial communication, in addition to a VSD that connects the left ventricle and the pulmonary artery arising from the hypoplastic right ventricle. Cyanosis is present virtually from birth, and there is a high early mortality, ABRV, with PDA without PDA. Cortation of aorta, RV. Figure 12.8 schematic of aortic cortation with and without pant ductus arteriosus. Cortation of the aorta, post-ductal type. The cortation is a segmental narrowing of the aorta. Such lesions typically manifest later in life than preductal cortations. The dilated ascending aorta and major branch vessels are to the left of the cortation. The lower extremities are perfused predominantly by way of dilated, tortuous collateral channels. Aorta, LA, left atrium, LV, left ventricle, PT, pulmonary trunk, right atrium, RV, right ventricle, PDA, pant ductus arteriosus. On the aortic lumen is variable, sometimes leaving only a small channel and at other times producing only minimal narrowing. Although cortation of the aorta may occur as a solitary defect, in 50% of cases it is accompanied by a bicuspid aortic valve and may also be associated with congenital aortic stenosis, as VSD, mitral regurgitation, or Berry aneurysms of the circle of Willis. Morphology. Preductal cortation is characterized by circumferential narrowing of the aortic segment between the left subclavian artery and the ductus arteriosus. The ductus typically is pant and is the main source of blood delivered to the distal aorta. The pulmonary trunk is dilated to accommodate the increased blood flow. Because the right side of the heart now perfuses the body distal to the narrowed segment, the right ventricle typically is hypertrophied. In the more common adult post-ductal cortation, the aorta is sharply constricted by a tissue ridge adjacent to the non-pant ligamentum arteriosum. The constricted segment is made up of smooth muscle and elastic fibers derived from the aortic media. Proximal to the cortation, the aortic arch and its branch vessels are dilated and the left ventricle is hypertrophied. Clinical features. Clinical manifestations depend on the severity of the narrowing and the patency of the ductus arteriosus. Cortation of the aorta with the PDA usually manifests early in life. Indeed, it may cause signs and symptoms immediately after birth. In such cases, the delivery of unsaturated blood through the PDA produces cyanosis localized to the lower half of the body. Many such infants do not survive the neonatal period without surgical or catheter-based intervention to occlude the PDA. The outlook is different with cortation of the aorta without a PDA, unless the aortic constriction is severe. Most children are asymptomatic, and the disease may go unrecognized until well into adult life. Typically, there is hypertension in the upper extremities with weak pulses and hypotension in the lower extremities, associated with manifestations of arterial insufficiency. Particularly characteristic is the development of collateral circulation between the precortation and postcortation arteries through enlarged intercostal and internal mammary arteries, often producing radiographically visible erosions of the undersurfaces of the ribs. With significant cortations, murmurs are present throughout systole. Sometimes a vibratory thrill is also present. The long-standing pressure overload leads to concentric left ventricular hypertrophy. With uncomplicated cortation of the aorta, surgical resection and end-to-end anastomosis or replacement of the affected aortic segment by a prosthetic graft yields excellent results. Pulmonary stenosis and atresia. Pulmonary stenosis or atresia is a relatively frequent malformation leading to obstruction at the level of the pulmonary valve. This can be mild to severe. The lesion can also be isolated or part of a more complex anomaly, either TOF or TGA. Right ventricular hypertrophy typically develops, and there is sometimes poststenotic dilation of the pulmonary artery due to injury of the wall by high-pressure jets through the stenotic valve. With coexistent subpulmonic stenosis, the pulmonary trunk is not dilated and may in fact be hypoplastic. When the valve is entirely atretic, there is no communication between the right ventricle and lungs. In such cases, the anomaly is associated with a hypoplastic right ventricle and an ASD. Blood reaches the lungs through a PDA. Mild stenosis may be asymptomatic and compatible with long life, whereas symptomatic cases require surgical correction. When the RV is severely hypoplastic, blood can be surgically routed directly from the vena cava to the pulmonary artery, bypassing the right side of the heart. Aortic stenosis and atresia congenital narrowing and obstruction of the aortic valve can occur at 3 locations: valvular, subvalvular, and supravalvular. Congenital aortic valve stenosis is an isolated lesion in 80% of cases. With valvular aortic stenosis, the cusps may be hypoplastic, dysplastic, or abnormal in number. In severe congenital aortic stenosis or atresia, obstruction of the left ventricular outflow tract leads to hypoplasia of the left ventricle and ascending aorta, sometimes accompanied by dense, porcelain-like left ventricular endocardial fibroelastosis. The ductus arteriosus must be penned to allow blood flow to the aorta and coronary arteries. The constellation of findings is called hypoplastic left heart syndrome, and unless PDA patency is preserved, duct closure in the first week of life is generally lethal. Affected patients require surgeries that allow the right ventricle to become the pump for the systemic circulation, with the lungs perfused from either a parallel right ventricular conduit or passively from the vena cava. Subaortic stenosis is caused by a thickened ring or collar of dense endocardial fibrous tissue below the level of the cusps. Supravalvular aortic stenosis is a congenital aortic dysplasia with thickening and constriction of the ascending aortic wall. Elastin gene mutations can cause supravalvular stenosis by disrupting elastin, smooth muscle cell interactions during aortic morphogenesis. Subaortic stenosis is usually associated with a prominent systolic murmur and sometimes a thrill. Pressure hypertrophy of the left ventricle develops as a consequence of the obstruction to blood flow. Unless very severe, the stenosis is generally well tolerated, although left ventricular hypertrophy still carries a risk of sudden cardiac death. Key concepts: congenital heart disease. CHE represents defects of cardiac chambers or the great vessels. These typically either result in shunting of blood between the right and left circulation or cause outflow obstruction. Lesions range from relatively asymptomatic to rapidly fatal. Environmental and genetic causes both contribute, and the manifestations depend on the timing of the environmental insult and which step in cardiac development is affected. Left or right shunts are most common and are typically associated with ASD, VSD, or PTA. These lesions result in chronic right-sided pressure and volume overloads that eventually cause pulmonary hypertension with reversal of flow, and right-to-left shunts with cyanosis. Right-to-left shunts are most commonly caused by TOF or TGA. These are cyanotic lesions from the outset and are associated with polycythemia, peripheral cyanosis effects, paradoxical emboli. Obstructive lesions include valve stenosis and aortic coarctation. The clinical severity of the lesion depends on the degree of stenosis and the patency of the ductus arteriosus. Ischemic heart disease. IHE represents a group of related entities resulting from myocardial ischemia, an imbalance between myocardial supply and cardiac demand for oxygenated blood. Ischemia not only limits tissue oxygenation, but also reduces the availability of nutrients and the removal of metabolic wastes. Thus, cardiac ischemia is generally less well tolerated than hypoxemia per se, such as may occur with severe anemia, cyanotic heart disease, or advanced lung disease. In more than 90% of cases, myocardial ischemia results from reduced blood flow due to obstructive atherosclerotic lesions in the epicardial coronary arteries. Consequently, IHD is frequently referred to as coronary artery disease. In most cases, there is a long period of silent, slow progression of coronary lesions before the sudden onset of symptoms. Thus, IHE is often a late manifestation of coronary atherosclerosis that began during childhood or adolescence. IHE can declare itself through one or more of the following clinical presentations: myocardial infarction, in which ischemia causes frank cardiac necrosis; angina pectoris, in which ischemia is not severe enough to cause infarction, but the symptoms nevertheless portend infarction risk; chronic IHD with heart failure; sudden cardiac death. In addition to coronary atherosclerosis, myocardial ischemia can be caused by coronary emboli, myocardial vessel inflammation, or vascular spasm. Moreover, otherwise modest coronary artery occlusions may become consequential in the setting of increased cardiac energy demand, hypoxemia, or systemic hypotension. Some conditions can have multiple deleterious effects. Thus, tachycardia increases oxygen demand while decreasing functional supply. Epidemiology: IHE is the single largest cause of mortality worldwide, accounting for over 12% of global deaths. In the industrialized nations, this amounts to over 7.5 million casualties each year. Even in low-income countries, advances in the treatment and prevention of infectious diseases and the increasing adoption of westernized diets is accelerating IHE incidence. It is predicted soon to become the leading cause of mortality there as well. At the same time, there is cause for optimism. Since peaking in the mid-1960 seconds, the overall death rate from IHD has fallen in the United States by over 50%. This remarkable improvement can be attributed to the following. Prevention, achieved by modifying important risk factors, such as smoking, level of blood cholesterol, and hypertension. Additional risk reduction can occur through weight loss, exercise, and maintaining good glycemic control in diabetic patients. Diagnostic and therapeutic advances, allowing earlier and more effective treatments. The latter include cholesterol-lowering drugs such as statins, thrombolysis for acute coronary occlusions, better medical management after MI, coronary angioplasty and stenting, coronary artery bypass graft surgery, and improved therapies for heart failure and arrhythmias using left VADs, implantable defibrillators, and cardiac resynchronization approaches. Even a simple daily prophylactic aspirin can have therapeutic benefit. Continuing this encouraging trend will be challenging, particularly in view of the increased longevity of baby boomers and the obesity epidemic. New therapeutic advances will depend on understanding the genetic determinants of coronary atherosclerosis and IHD. Thus, the observation that MIs occur in only a fraction of individuals with coronary disease suggests that simple control of atherosclerotic risk factors is only part of the story. Pathogenesis. The dominant cause of IHD syndromes is insufficient coronary perfusion relative to myocardial demand. In the vast majority of cases, this is due to either of the following. Chronic, progressive atherosclerotic narrowing of the epicardial coronary arteries, variable degrees of superimposed acute plaque change, thrombosis, and vasospasm. The individual elements and their interactions are discussed next. Chronic vascular occlusion. More than 90% of patients with IHD have atherosclerosis involving one or more of the epicardial coronary arteries. A fixed lesion obstructing greater than 70% of vascular cross-sectional area is typically cited as the threshold for symptomatic ischemia precipitated by exercise. With this degree of obstruction, compensatory coronary arterial vasodilation is no longer sufficient to meet even moderate increases in myocardial demand. Obstruction of 90% of the cross-sectional area of the lumen generally leads to inadequate coronary blood flow, even at rest. Slowly developing obstructions induce the formation of collateral circulation that can mitigate the effects of even high-grade stenosis by allowing alternate channels to perfuse at-risk myocardia. Consequently, rather than just assessing the extent of local vascular stenosis, measurements of coronary flow across the stenosis provide a better assessment of the consequences of fixed coronary artery occlusions, particularly when multifocal. Although only a single major coronary epicardial vessel may be affected, two or all three, the left anterior descending, left circumflex, and right coronary artery, are often involved simultaneously by obstructive atherosclerosis. Clinically significant plaques can be located anywhere along the course of the vessels, although they tend to predominate within the first several centimeters of the LAD and LCX. Sometimes the major epicardial branches are also involved, but atherosclerosis of the intramyocardial branches is rare. Thus, most atherosclerotic stenosis can be accessed by coronary catheterization. Acute plaque change. The risk of an individual developing clinically important IHD depends in part on the number, distribution, structure, and degree of obstruction by atheromatous plaques. However, the very clinical manifestations of IHD cannot be explained by the anatomic disease burden and fixed stenosis alone. This is particularly true for the so-called acute coronary syndromes, namely when unstable angina, acute MI, and sudden death are caused abruptly by acute plaque changes. These acute coronary syndromes are typically initiated by an unpredictable and sudden conversion of a stable atherosclerotic plaque to an unstable and potentially life-threatening atherothrombotic lesion through rupture, superficial erosion, ulceration, fissuring, or deep hemorrhage. In most instances, acute plaque changes, typically associated with intralesional inflammation, precipitate the formation of a superimposed thrombus that partially or completely occludes the artery. It remains to be seen whether aggressive anti-inflammatory regimens are means to reduce such acute coronary events. Consequences of myocardial ischemia. Stable angina results from increases in myocardial oxygen demand that outstrip the ability of coronary arteries with fixed stenosis to increase oxygen delivery. It is usually not associated with plaque disruption. Unstable angina is caused by acute plaque change that results in thrombosis and/or vasoconstriction, and leads to incomplete or transient reductions in coronary blood flow. In some cases, microinfarcts can occur distal to disrupted plaques due to thromboemboli. MI is often the result of acute plaque change that induces an abrupt thrombotic occlusion, resulting in myocardial necrosis. Sudden cardiac death may be caused by regional myocardial ischemia that induces a fatal ventricular arrhythmia. This can result from a fixed stenosis or acute plaque change. Each of these important syndromes is discussed in detail next, followed by an examination of the important myocardial consequences. Angina pectoris. Angina pectoris is characterized by paroxysmal and usually recurrent attacks of substernal or precordial chest discomfort caused by transient myocardial ischemia that is insufficient to induce myocyte necrosis. The anginal pain is a consequence of the ischemia-induced release of adenosine, rhyndicinin, and other molecules that stimulate sympathetic and vagal afferent nerves. 3 overlapping patterns of angina pectoris are recognized, caused by varying combinations of decreased perfusion, increased demand, and coronary arterial pathology. Importantly, not all ischemic events are perceived by patients. Silent ischemia is particularly common in the geriatric population and in the setting of diabetic neuropathy. Stable angina is the most common form of angina. It is caused by an imbalance in coronary perfusion relative to myocardial demand. Stable angina does not occur at rest, but in a given patient can be reliably induced by activities that increase the energy requirements of the heart, including physical activity, emotional excitement, or psychological stress. Angina pectoris is classically described as a crushing or squeezing substernal sensation that can radiate down the left arm or to the left jaw. The pain is usually relieved by rest or by administering vasodilators, such as nitroglycerin and calcium channel blockers. Prinzmetal variant angina is an uncommon form of episodic myocardial ischemia caused by coronary artery spasm. Although individuals with Prinzmetal variant angina can also have significant coronary atherosclerosis, the anginal attacks are unrelated to physical activity, heart rate, or blood pressure, and can occur at rest. Prinzmetal angina generally responds promptly to vasodilators. Unstable or crescendo angina refers to a pattern of increasingly frequent, prolonged, or severe angina, precipitated by progressively lower levels of physical activity or even occurring at rest. Unstable angina is associated with plaque disruption and superimposed thrombosis, distal embolization of the thrombus, and /or vas spasm. It is an important harbinger of MI, potentially portending complete vascular occlusion. Myocardial infarction, MI, also commonly referred to as heart attack, is the death of cardiac muscle due to prolonged ischemia. Roughly 1.5 million individuals in the United States suffer an MI each year, causing approximately 610,000 deaths annually. The major underlying cause of IHD is atherosclerosis. Although MIs can occur at virtually any age, 10% of MIs occur in people younger than 40 years of age, and 45% occur in people younger than 65 years of age. Nevertheless, the frequency rises progressively with increasing age and with increasing atherosclerotic risk factors. Through middle age, male gender increases the relative risk of MI. Indeed, women are generally protected against MI during their reproductive years. However, postmenopausal decline in estrogen production is usually associated with accelerated CAD, and IHD is the most common cause of death in older women. Unfortunately, postmenopausal hormonal replacement therapy has not been shown to be protective, and in fact, in some cases, may be detrimental. Pathogenesis, coronary arterial occlusion. The following sequence of events likely underlies most MIs. An atheromatous plaque is eroded or suddenly disrupted by endothelial injury, intraplaque hemorrhage, or mechanical forces, exposing subendothelial collagen and necrotic plaque contents to the blood. Platelets adhere, aggregate, and are activated, releasing thromboxane ATRO, adenosine diphosphate, and serotonin, causing further platelet aggregation and vasospasm. Activation of coagulation by tissue factor and other mechanisms adds to the growing thrombus. Within minutes, the thrombus can evolve to completely occlude the coronary artery lumen. The evidence for this scenario derives from autopsy studies of patients dying of acute MI, as well as imaging studies demonstrating a high frequency of thrombotic occlusion early after MI. Interestingly, comparison to prior angiograms shows that these thrombi are usually at a site that did not previously have a critical fixed stenosis. Typically, when angiography is performed within 4 hours of the onset of MI, it demonstrates coronary thrombosis in almost 90% of cases. However, when angiography is performed 12 to 24 hours after onset of symptoms, evidence of thrombosis is seen in only 60% of patients, even without intervention. Thus, at least some occlusions clear spontaneously through lysis of the thrombus or relaxation of spasm. This sequence of events in a typical MI also has therapeutic implications. Early thrombolysis and /or angioplasty can be highly successful in limiting the extent of myocardial necrosis. In approximately 10% of cases, MI occurs in the absence of the typical coronary atherothrombosis. In such situations, other mechanisms may be responsible for the reduced coronary blood flow. Vasospasm with or without coronary atherosclerosis, perhaps in association with platelet aggregation or due to drug ingestion. Emboli from the left atrium in association with atrial fibrillation, a left-sided mural thrombus. Vegetations of infective endocarditis, intracardiac prosthetic material, or paradoxical emboli from the right side of the heart, or the peripheral veins traversing a patent foramen ovale and into the coronary arteries. Uncommon causes of MI without atherothrombosis include disorders of small intramural coronary vessels, hemorrhagic abnormalities, amyloid deposition in vascular walls, vascular dissection, marked hypertrophy, lowered systemic blood pressure, or inadequate myocardial protection during cardiac surgery. Myocardial response. Coronary arterial obstruction diminishes blood flow to a region of myocardium, causing ischemia, rapid myocardial dysfunction, and eventually with prolonged vascular compromise, myocyte death. The anatomic region supplied by that artery is referred to as the area at risk. The outcome depends predominantly on the severity and duration of flow deprivation. The early biochemical consequence of myocardial ischemia is the cessation of aerobic metabolism within seconds, leading to inadequate production of high-energy phosphates and accumulation of potentially noxious metabolites. Because of the exquisite dependence of myocardial function on oxygen and nutrients, myocardial contractility ceases within a minute or so of the onset of severe ischemia. Such loss of function contributes to decreased systolic function long before myocyte death occurs. As detailed in Chapter 2, ultrastructural changes also develop within a few minutes. ATP and lactate onset of irreversible injury. Lactate, ATP fraction of at risk myocardium. 0, 5, 10, 15, 20, 30, 40, 50 minutes beat time. 20, 100, 80. Reversible phase, irreversible phase. Ischemic myocardium potentially salvageable by timely intervention. Cumulative dead myocardium. 2, 3, 5, 6, 1, 2, 1, 8 hours. Figure 12.9 temporal sequence of early biochemical findings and progression of cardiomyocyte necrosis after onset of severe myocardial ischemia. Early changes include loss of adenosine triphosphate and accumulation of lactate. For approximately 30 minutes after the onset of even the most severe ischemia, myocardial injury is potentially reversible. Thereafter, progressive loss of viability occurs that becomes complete by 6 to 12 hours. The benefits of reperfusion are greatest when it is achieved early and are progressively lost when reperfusion is delayed. Of the onset of ischemia. Nevertheless, these early manifestations of ischemic injury are potentially reversible. Indeed, experimental and clinical evidence shows that only severe ischemia lasting 20 to 30 minutes or longer leads to irreversible damage of cardiac myocytes. This delay in the onset of permanent myocardial injury provides the rationale for rapid diagnosis in acute MI, to permit early coronary intervention to establish reperfusion and salvage as much at-risk myocardium as possible. The earliest detectable feature of myocyte necrosis is disruption of the integrity of the sarcomal membrane, allowing intracellular macromolecules to leak out of necrotic cells into the cardiac interstitium and ultimately into the microvasculature and lymphatics. This escape of intracellular myocardial proteins into the circulation forms the basis for blood tests that can sensitively detect irreversible myocyte damage and are important for managing MI. With prolonged severe ischemia, injury to the microvasculature follows injury to the cardiac myocytes. The temporal progression of these events is summarized in Table 12.4. Table 12.4 Approximate time of onset of key events in ischemic cardiac myocytes. Feature time. Onset of ATP depletion seconds. Loss of contractility 2 minutes. ATP reduced to 50% of normal 10 minutes to 10% of normal 40 minutes. Irreversible cell injury 20, 40 minutes. Microvascular injury 1 hour. Adenosine triphosphate. The progression of ischemic necrosis in the myocardium is summarized in Fig. 12.10. Irreversible injury of ischemic myocytes first occurs in the subendocardial zone. This region is especially susceptible to ischemia because it is the last area to receive blood delivered by the epicardial vessels, and also because it is exposed to relatively high intramural. Aorta, pulmonary, artery, left circumflex coronary artery, right coronary artery, left anterior descending coronary artery, acute coronary arterial occlusion. Zone of perfusion, cross-section of myocardium, completed infarct involving nearly the entire area at risk, obstructed coronary artery, endocardium, zone of perfusion. Zone of necrosis, 0 HR 2 HR 24 HR. Figure 12.10 Progression of myocardial necrosis after coronary artery occlusion. Necrosis begins in a small zone of the myocardium beneath the endocardial surface in the center of the ischemic zone. The area that depends on the occluded vessel for perfusion is the at-risk myocardium. Note that a very narrow zone of myocardium immediately beneath the endocardium is spared from necrosis because oxygen and nutrition can be provided by diffusion from the ventricle. Pressures, which act to impede the inflow of blood. With more prolonged ischemia, a wave of cell death moves through other regions of the myocardium, driven by progressive tissue edema and myocardial-derived reactive oxygen species and inflammatory mediators. The location, size, and specific morphologic features of an acute MI depend on the following: the location, severity, and rate of development of coronary obstructions due to atherosclerosis and thrombosis, the size of the vascular bed perfused by the obstructed vessels, the duration of the occlusion, the metabolic and oxygen needs of the myocardium at risk, the extent of vascular collateralization, the presence, site, and severity of coronary arterial spasm. Other factors, such as heart rate, cardiac rhythm, and blood oxygenation. An infarct usually achieves its full extent within 3 to 6 hours. In the absence of intervention, an infarct caused by occlusion of an epicardial vessel can involve the entire wall thickness. Clinical intervention within this critical window of time can lessen the size of the infarct within the territory at risk. Patterns of infarction. The distribution of myocardial necrosis correlates with the location and cause of the decreased perfusion. Knowledge of the areas of myocardium perfused by the major coronary arteries allows correlation of specific vascular obstructions with their corresponding areas of MI. Typically, the LAD branch of the left coronary artery supplies most of the apex of the heart, the anterior wall of the left ventricle, and the anterior 2/3 of the ventricular septum. By convention, the coronary artery, either RCA or LCX, that perfuses the posterior third of the septum is called dominant. In a right dominant circulation, the RCA supplies the entire right ventricular free wall, the posterobasal wall of the left ventricle, and the posterior third of the ventricular septum, and the LCX generally perfuses only the lateral wall of the left ventricle. Thus, RCA occlusions can potentially lead to left ventricular damage. Although most hearts have numerous intercoronary anastomosis, relatively little blood normally courses through these. However, when a coronary artery is progressively narrowed over time, blood flows via the collaterals from the high to the low pressure circulation, causing the channels to enlarge. Through such progressive dilation and growth of collaterals, stimulated by ischemia, blood flow is provided to areas of myocardium that would otherwise be deprived of adequate perfusion. Indeed, in the setting of extensive collateralization, the normal epicardial perfusion territories may be so expanded that subsequent occlusion leads to infarction and paradoxical distributions. Transmural infarctions occur when there is occlusion of an epicardial vessel. The necrosis involves virtually the full thickness of the ventricular wall in the distribution of the affected coronary. This pattern of infarction is usually associated with a combination of chronic coronary atherosclerosis, acute transmural infarcts, non-transmural infarcts. Restoration of flow. Permanent occlusion of left anterior descending branch, transient/partial obstruction, regional subendocardial, infarct, posterior. Permanent occlusion of left circumflex branch, permanent occlusion of right coronary artery, RVLV, anterior. Global hypotension, circumferential subendocardial, infarct. Small intramural vessel occlusions, myoinfarcts. Figure 12.11. Distribution of myocardial ischemic necrosis correlates with the location and nature of decreased perfusion. Left, the positions of transmural acute infarcts resulting from occlusions of the major coronary arteries, top to bottom, left anterior descending, left circumflex, and right coronary arteries. Right, the types of infarcts that result from a partial or transient occlusion, global hypotension, or intramural small vessel occlusions, plaque change, and superimposed thrombosis. Subendocardial infarctions can occur as a result of a plaque disruption followed by a coronary thrombus that becomes lysis before myocardial necrosis extends across the full thickness of the wall. Subendocardial infarcts can also result from prolonged, severe reduction in systemic blood pressure, as in shock superimposed on chronic, otherwise non-critical, coronary stenosis. In the subendocardial infarcts that occur as a result of global hypotension, myocardial damage is often circumferential, rather than being limited to the distribution of a single major coronary artery. Multifocal myoinfarction refers to a pattern that is seen when there is pathology involving only smaller intramural vessels. It can occur in the setting of myoembolization, vasculitis, or vascular spasm, for example, due to endogenous catecholamines or drugs. Elevated levels of catecholamines also increase heart rate and myocardial contractility, exacerbating ischemia caused by the vasospasm. The outcome of such vasospasm can be sudden cardiac death or an ischemic dilated cardiomyopathy. Morphology. The temporal evolution of the morphologic changes in acute MI and subsequent healing are summarized in Table 12.5. Nearly all transmural infarcts involve at least a portion of the left ventricle. They encompass nearly the entire perfusion zone of the occluded coronary artery, save for a narrow rim of viable subendocardial myocardium that is preserved by diffusion of oxygen and nutrients from the ventricular lumen. The frequencies of involvement of each of the three main arterial trunks and the corresponding sites of myocardial lesions resulting in infarction are as follows. Left anterior descending coronary artery, infarcts involving the anterior wall of left ventricle near the apex, the anterior portion of ventricular septum, and the apex circumferentially. Right coronary artery, infarcts involving the inferior/posterior wall of the left ventricle, posterior portion of ventricular septum, and the inferior/posterior right ventricular free wall in some cases. Left circumflex coronary artery, infarcts involving the lateral wall of the left ventricle except at the apex. Other locations of critical coronary arterial lesions causing infarcts are sometimes encountered, such as the left main coronary artery, the secondary branches of the left anterior descending coronary artery, or the marginal branches of the left circumflex coronary artery. Of MIs caused by right coronary obstruction, 15% to 30% extend from the posterior free wall of the septal portion of the left ventricle into the adjacent right ventricular wall. Isolated infarction of the right ventricle is unusual, as is infarction of the atria. The gross and microscopic appearance of an infarct depends on the interval of time between the MI and death. Damaged myocardium undergoes a progressive sequence of morphologic changes involving typical ischemic coagulative necrosis, the predominant mechanism of cell death in MI, although apoptosis. Table 12.5 Evolution of morphologic changes in myocardial infarction time. Gross features light microscope. Reversible injury 0, 1 2 hour. Irreversible injury 1 2 4 hours, 4 12 hours, 12 24 hours. Dark modeling 1 3 days modeling with yellow tan infarct. Center 3 7 days hyperemic border. Central yellow tan softening 7 10 days maximally yellow tan and soft, with depressed red tan margins, red-gray depressed infarct borders. 10 14 days 2 8 weeks gray white scar, progressive from border toward core of infarct. Scarring complete 2 months, usually none. Variable waviness of fibers at border. Early coagulative necrosis, edema, hemorrhage. Ongoing coagulative necrosis, pycnosis of nuclei, myocyte hypereosinophilia, marginal contraction band necrosis. Early neutrophilic infiltrate, coagulative necrosis, with loss of nuclei and striations, risk interstitial infiltrate of neutrophils. Beginning disintegration of dead myofibers, with dying neutrophils, early phagocytosis of dead cells by macrophages at infarct border, well-developed phagocytosis of dead cells. Granulation tissue at margins, well-established granulation tissue with no blood vessels and collagen deposition, increased collagen deposition, with decreased cellularity. Des collagen score. Electron microscope, relaxation of myofibrils, glycogen loss, mitochondrial swelling, sarcomal disruption, mitochondrial amorphous densities can also occur. This is followed by stereotypical inflammation and repair that parallels responses to injury in other tissues. Early morphologic recognition of acute MI can be difficult, particularly when death occurs within only a few hours of symptom onset. MIs less than 12 hours old are usually not apparent on gross examination alone. However, if the infarct preceded death by at least 2 to 3 hours, it is possible to highlight the area of necrosis by immersion of tissue slices in a solution of triphenyl tetrazolium chloride. This gross histochemical stain imparts a brick red color to intact, non-infarcted myocardium with preserved lactate dehydrogenase activity. Because dehydrogenases leak out through the damaged membranes of dead cells, an infarct appears as an unstained pale zone. By 12 to 24 hours after infarction, an MI can usually be identified grossly as a reddish-blue area of discoloration caused by congestion and extravasated blood. By 3 to 7 days, it is rimmed by a hyperemic zone of highly vascularized early wound healing. Thereafter, the infarct becomes progressively more sharply defined, yellow tan, and soft. Over the succeeding weeks, the injured region evolves to a fibrous scar. The histopathologic changes also proceed in a fairly predictable sequence. The typical changes of coagulative necrosis become detectable in the first 6 to 12 hours. Wavy fibers may. Figure 12.12 acute myocardial infarct, predominantly of the posterolateral left ventricle, demonstrated histochemically by a lack of staining by triphenyl tetrazolium chloride in areas of necrosis. The staining defect is due to the lactate dehydrogenase leakage that follows cell death. Note the myocardial hemorrhage at one edge of the infarct that was associated with cardiac rupture and the anterior scar, indicative of an old infarct. The specimen is oriented with the posterior wall at the top. A BCDE, figure 12.13 microscopic features of myocardial infarction and its repair. One-day-old infarct showing coagulative necrosis and wavy fibers. Widened spaces between the dead fibers contain edema fluid and scattered neutrophils. There's polymorphonucleoleucocytic infiltrate in an acute myocardial infarction that is 3 to 4 days old. Removal of necrotic myocytes by phagocytosis. Granulation tissue characterized by loose collagen and abundant capillaries. Healed myocardial infarct in which the necrotic tissue has been replaced by a dense collagen scar. The residual cardiac muscle cells show evidence of compensatory hypertrophy. D and E are stained with Massen's trichome, rendering collagenous connective tissue a deep blue color. Note the accumulation of extracellular matrix between the early granulation tissue and the subsequent dense scar. Be present at the periphery of the infarct, resulting from the contractions of viable myocardium that cause the stretching and buckling of adjacent, non-contractile dead fibers. An additional subaortal ischemic change may be seen in the margins of infarcts. The so-called myocyte vacuolization reflects intracellular accumulations of salt and water within the sarcoplasmic reticulum and marks myocytes that are viable but poorly contractile. Necrotic myocardium elicits acute inflammation typically most prominent 1 to 3 days after MI, followed by a wave of macrophages that remove necrotic myocytes and neutrophil fragments. The infarcted zone is progressively replaced by granulation tissue, which in turn forms the provisional scaffolding on which dense collagenous scar forms. Because cardiac myocytes are terminally differentiated cells, no cardiomyocyte proliferation is seen. In most instances, scarring is well advanced by the end of the 6th week, but the efficiency of repair depends on the size of the original lesion and the ability of the host tissues to heal. Healing requires the migration of inflammatory cells and ingrowth of new vessels from the infarct margins. Thus, an MI heals from its borders toward the center, and a large infarct may not heal as fast or as completely as a small one. Moreover, malnutrition, poor vasculature, or exogenous anti-inflammatory steroids can impede effective infarct scarring. Once an MI is completely healed, it is impossible to distinguish its age, whether present for 8 weeks or 10 years. Fibrous scars look the same. The following discussion considers the changes that result from interventions that can limit infarct size by salvaging myocardium that is not yet necrotic. Infarct modification by reperfusion. The therapeutic goal in acute MI is to salvage the maximal amount of ischemic myocardium. This is accomplished by restoration of tissue perfusion as quickly as possible. Such reperfusion is achieved by thrombolysis, angioplasty, or coronary arterial bypass graft. Unfortunately, although preservation of viable heart can improve both short and long-term outcomes, reperfusion is not an unalloyed blessing. Indeed, late restoration of blood flow into ischemic tissues can be associated with arrhythmias and can incite greater local damage than might otherwise have occurred. So-called reperfusion injury. The effects of reperfusion on myocardial viability and function are summarized in Fig. 12.14. Although the clinical significance of myocardial reperfusion injury is debated, it has been estimated that up to 50% of the ultimate infarct size can be attributed to its effects. To date, clinical trials to prevent reperfusion injury have not been fruitful, but this remains an active area of investigation. Factors that contribute to reperfusion injury include the following. Mitochondrial dysfunction. Ischemia alters the mitochondrial membrane permeability, which allows proteins to move into the mitochondria. This leads to swelling and rupture of the outer membrane, releasing mitochondrial contents that promote apoptosis. Myocyte hypercontraction. During periods of ischemia, the intracellular levels of calcium are increased as a result of impaired calcium cycling and sarcomal damage. After reperfusion, the contraction of myofibrils is augmented and uncontrolled, causing cytoskeletal damage and cell death. Free radicals including superoxide anion, hydrogen peroxide, hypochlorous acid, nitric oxide, derived peroxynitrite, and hydroxyl radicals are produced within minutes of reperfusion and cause damage to the myocytes by altering membrane proteins and phospholipids. Leukocyte aggregation, which may occlude the microvasculature and contribute to the no-reflow phenomenon. Further, leukocytes elaborate proteases and elastases that cause cell death. Platelet and complement activation also contribute to microvascular injury. Complement activation is thought to play a role in the no-reflow phenomenon by injuring the endothelium. Permanent occlusion, temporary occlusion with reperfusion. 100% of original viability function. 100% restoration of flow. Salvage, reperfusion injury. Post-ischemic ventricular dysfunction. A. 0%. 0 2 minute 20 minute 120 minute time. Figure 12.14 effects of reperfusion on myocardial viability and function. After coronary occlusion, contractile function is lost within 2 minutes, and viability begins to diminish after approximately 20 minutes. If perfusion is not restored, then nearly all myocardium in the affected region suffers death. If flow is restored, then some necrosis is prevented, myocardium is salvaged, and at least some function can return. The earlier reperfusion occurs, the greater the degree of salvage. However, the process of reperfusion itself may induce some damage, and return of function of salvaged myocardium may be delayed for hours to days. 6HR 0%, 0 to 2 minute, 20 minute, 120 minute, B time, 6 HR days. A B figure 12.15 consequences of myocardial ischemia followed by reperfusion. Gross and microscopic appearance of myocardium modified by reperfusion. Large, densely hemorrhagic, anterior wall acute myocardial infarction in a patient with left anterior descending artery thrombus treated with streptokinase, a fibrinolytic agent. Specimen oriented with posterior wall at top. Myocardial necrosis with hemorrhage and contraction bands, visible as dark bands spanning some myofibers. The typical appearance of reperfused myocardium in the setting of an acute MI is shown in Fig. 12.15. Such infarcts typically are hemorrhagic as a consequence of vascular injury and leakiness. Microscopically, irreversibly damaged myocytes after reperfusion develop contraction band necrosis. In this pathologic process, intense eosinophilic bands of hypercontracted sarcomeres are created by an influx of calcium across plasma membranes that heightens actin-myosin interactions. In the absence of ATP, the sarcomeres cannot relax and get stuck in an agonal tetanic state. Thus, although reperfusion can salvage reversibly injured cells, it also alters the morphology of irreversibly injured cells. The biochemical abnormalities may also persist for days to weeks in reperfused myocytes. Such changes are thought to underlie a phenomenon referred to as stunned myocardium, a state of prolonged contractile dysfunction induced by short-term ischemia that usually recovers after several days. Myocardium that is subjected to chronic, subophyll ischemia can also enter into a state of lowered metabolism and function called hibernation. Subsequent revascularization often restores normal function to such hibernating myocardium. Clinical features. MI is diagnosed by clinical symptoms, laboratory tests for the presence of myocardial proteins in the plasma, and characteristic electrocardiographic changes. Patients with MI classically present with prolonged chest pain described as crushing, stabbing, or squeezing, associated with a rapid, weak pulse. Profuse sweating and nausea and vomiting are common and can suggest involvement of the posterior or inferior ventricle with secondary vagal stimulation. Dyspnea due to impaired contractility of the ischemic myocardium and the resultant pulmonary congestion and edema is a frequent symptom. However, in as many as 25% of patients the onset is entirely asymptomatic, and the disease is discovered only by electrocardiographic changes or laboratory tests that show evidence of myocardial damage. Owing to the characteristic electrocardiographic changes resulting from myocardial ischemia or necrosis in various distributions, a transmural infarct is sometimes referred to as insane elevation myocardial infarct and a subendocardial infarct as a non-insane elevation infarct. Depending on the extent and location of the vascular involvement, microinfarctions show nonspecific changes or can even be electrocardiographically silent. The laboratory evaluation of MI is based on measuring the blood levels of proteins that leak out of irreversibly damaged myocytes. Previously, this involved measurement of the MB fraction of creatine kinase. Currently, the most clinically useful biomarkers of myocardial damage are cardiac-specific troponins T and I, proteins that normally regulate calcium-mediated contraction of cardiac muscle. The diagnosis of myocardial injury is established when blood levels of troponin are elevated above threshold levels. The tempo and magnitude of appearance of these serum markers after MI depends on several factors, including the volume of damaged myocardium, blood flow and lymphatic drainage in the area of the infarct, and the rate of elimination of the marker from the blood. Cardiac troponins begin to rise in 2 to 4 hours and peak at 24 to 48 hours after an acute infarct. With reperfusion, troponin levels may be higher and peak earlier owing to more rapid washout of the marker from the necrotic tissue. Significant acute elevation in serum troponin can also be seen in other conditions that cause death of cardiac myocytes, such as myocarditis and myocardial trauma. On the other hand, low-level serum troponin elevation can occur in a host of other conditions, including congestive heart failure, pulmonary embolus, renal failure, and sepsis. These elevations do not usually follow the same abrupt injury time course, so serial measurements may be helpful in distinguishing different etiologies. Recommended initial therapies for acute MI make sense based on the pathophysiologic features discussed earlier and include the following. Oxygen supplementation to improve blood oxygen saturation for patients with hypoxia or respiratory distress. Nitrates to induce vasodilation and reverse vasospasm. Acute myocardial infarction. 1. Onset of myocardial infarction. 2. Plasma membrane of necrotic myocytes becomes leaky. Figure 12.16 Release of myocyte proteins in myocardial infarction. Troponin or troponin T are now most routinely used as diagnostic biomarkers of myocyte injury. Troponin-free in cytoplasm. Troponin complex released from actin filament. 3 troponin leaks. Out of cell into circulation. Relative concentration. 150. 20.105.2.1.0.0. Cardiac troponin. No reperfusion. With reperfusion. Upper reference limit. 1, 2, 3, 4, 5, 6, 7 days after onset of acute MI. 4. Biomarker for diagnosis of myocardial infarction. Antiplatelet agents such as aspirin, ADP receptor inhibitors, and GPA/E inhibitors. Anticoagulant therapy with unfractionated heparin, low molecular weight heparin, direct thrombin inhibitors, and /or factors I inhibitors to prevent coronary artery thrombus propagation. Beta blockers to decrease myocardial oxygen demand and to reduce the risk of arrhythmias, unless contraindicated such as in heart failure. Prompt reperfusion to salvage myocardium by either fibrinolytic medications or transcatheter interventions. Improve myocardial oxygen supply versus demand by management of other factors, such as anxiety, ischemic pain, abnormal hemodynamics, anemia, and respiratory disorders. Early arrhythmia monitoring and management. Consequences and complications of myocardial infarction. Extraordinary progress has been made in improving patient outcomes after acute MI. The overall in-hospital death rate for MI is approximately 7% to 8%, with STEMI patients experiencing slightly higher mortality than NSTEMI patients. Unfortunately, mortality for out-of-hospital MIs is substantially worse. 1/3 of patients who are unfortunate enough to suffer a STEMI at home will die, usually of an arrhythmia within 1 hour of symptom onset and before they can receive medical attention. Such statistics make the rising rate of CAD in countries with limited hospital facilities all the more worrisome. Nearly 3/4 of patients experience one or more of the following complications after an acute MI. Contractile dysfunction. In general, MIs affect left ventricular pump function in proportion to the volume of damage. In most cases, there is some degree of left ventricular failure manifested as hypotension, pulmonary congestion, and pulmonary edema. Severe pump failure occurs in roughly 10% of patients with transmural MIs and typically is associated with infarcts that damage 40% or more of the left ventricle. Papillary muscle dysfunction. Although papillary muscles rupture infrequently after MI, they often are dysfunctional and can be poorly contractile as a result of ischemia, leading to post-infarct mitral regurgitation. Much later, papillary muscle fibrosis and shortening, or global ventricular dilation also can cause mitral regurgitation, right ventricular infarction. Although isolated right ventricular infarction occurs in only 1% to 3% of MIs, the right ventricle is affected by RCA occlusions leading to posterior septal or left ventricular infarction. In either case, right-sided heart failure is a common outcome, leading to pooling of blood in the venous circulation and systemic hypotension. Myocardial rupture. Rupture complicates only 1% to 5% of MIs, but is frequently fatal when it occurs. Left ventricular free wall rupture is most common, usually resulting in rapidly fatal hemopericardium and cardiac tamponade. Ventricular septal rupture creates a VSD with left to right shunting, and papillary muscle rupture leads to severe mitral regurgitation. Rupture occurs most commonly within 3 to 7 days after infarction, the time in the healing process when lysis of necrotic myocardium is maximal and when much of the infarct has been converted to soft, free blood granulation tissue. Risk factors for free wall rupture include age older than 60 years, anterior or lateral wall infarctions, female gender, lack of left ventricular hypertrophy, and first MI. Arrhythmias. MIs lead to myocardial irritability and conduction disturbances that can cause sudden death. Approximately 90% of patients develop some form of rhythm disturbance, with the incidence being higher in STEMI versus NSTEMI. MI-associated arrhythmias include heart block of variable degree, a BC, DEF figure 12.17 complications of myocardial infarction. Anterior myocardial rupture in an acute infarct. Rupture of the ventricular septum. Complete rupture of a necrotic papillary muscle. Fibrinous pericarditis, showing a dark, roughened epicardial surface overlying an acute infarct. Early expansion of anteroapical infarct with wall thinning and mural thrombus. F. Large apical left ventricular aneurysm. The left ventricle is on the right in this apical 4-chamber view of the heart. Bradycardia. Supraventricular tachyarrhythmias, ventricular premature contractions or ventricular tachycardia, and ventricular fibrillation. The risk for serious arrhythmias is greatest in the first hour and declines thereafter. Pericarditis. Transmural MIs can elicit a fibrinohemorrhagic pericarditis. This is an epicardial manifestation of the underlying myocardial inflammation. Heralded by anterior chest pain and a pericardial friction rub, pericarditis typically appears 2 to 3 days after infarction and then gradually resolves over the next few days. Extensive infarcts or severe pericardial inflammation occasionally can lead to large effusions or can organize to form dense adhesions that eventually manifest as a constrictive lesion. Rarely, patients can develop an intense pericarditis weeks after MI due to formation of antibodies against damaged myocardium, chamber dilation. Because of the weakening of necrotic muscle, there may be disproportionate stretching, thinning, and dilation of the infarcted region. Mural thrombus. With any infarct, the combination of attenuated myocardial contractility, chamber dilation, and endocardial damage causing a thrombogenic surface can foster mural thrombosis, potentially leading to left-sided thromboembolism. Ventricular aneurysm. A late complication, aneurysms of the ventricle most commonly result from a large transmural anterostal infarct that heals with the formation of a thin wall of scar tissue. Although ventricular aneurysms frequently give rise to formation of mural thrombi, arrhythmias, and heart failure, they do not rupture. Progressive heart failure. This is discussed in the chronic ischemic heart disease section later in this chapter. The risk of post-infarct complications and the prognosis of the patient depend primarily on the infarct size, location, and fraction of the wall thickness involved. Thus, large transmural infarcts yield a high probability of cardiogenic shock, arrhythmias, and late CHF. Patients with anterior transmural infarcts are at greatest risk for free wall rupture, expansion, mural thrombi, and aneurysm. In contrast, posterior transmural infarcts are more likely to be complicated by conduction blocks, right ventricular involvement, or both. When acute VSDs occur in this area, they are more difficult to manage. Moreover, female gender, age older than 70 years, diabetes mellitus, and previous MI are poor prognostic factors in patients with same elevation myocardial infarcts. With subendocardial infarcts, only rarely do pericarditis, rupture, and aneurysm occur. In addition to the sequence of repair in the infarcted tissues described earlier, the non-infarcted segments of the ventricle undergo hypertrophy and dilation. Collectively, these changes are termed ventricular remodeling. The compensatory hypertrophy of non-infarcted myocardium is initially hemodynamically beneficial. However, this adaptive effect may be overwhelmed by ventricular dilation and increased oxygen demand, which can exacerbate ischemia and depress cardiac function. There may also be changes in ventricular shape and stiffening of the ventricle due to scar formation and hypertrophy that further diminish cardiac output. Some of these deleterious effects appear to be reduced by AC inhibitors, which lessen the ventricular remodeling that can occur after infarction. Long-term prognosis after MI depends on many factors, the most important of which are the residual left ventricular function and the extent of any vascular obstructions and vessels that perfuse the remaining viable myocardium. The overall total mortality within the first year can be as high as 30%. Thereafter, each passing year is associated with an additional 3% to 4% mortality among survivors. Infarct prevention in individuals who have never experienced MI and prevention of reinfarction in MI survivors are important strategies that have received much attention and achieved considerable success. The relationship of the causes, pathophysiology, and consequences of MI are summarized in Fig. 12.18, including the possible outcomes of chronic IHD and sudden death, discussed later. Chronic ischemic heart disease. The designation chronic IHD is used here to describe progressive congestive heart failure as a consequence of accumulated ischemic myocardial damage and/or inadequate compensatory responses. In most instances, there has been a prior MI and sometimes previous coronary arterial interventions and/or bypass surgery. Chronic IHD usually appears post-infarction due to the functional decompensation of hypertrophied non-infarcted myocardium. However, in other cases, severe obstructive CAD may present as chronic congestive heart failure in the absence of prior infarction. Patients with chronic IHD account for almost 50% of cardiac transplant recipients. Morphology. Patients with chronic IHD have cardiomegaly, with left ventricular hypertrophy and dilation. Invariably, there is some degree of stenotic coronary atherosclerosis. Discrete scars representing healed infarcts are usually present. The mural endocardium often has patchy fibrous thickenings, and mural thrombi may be present. Microscopic findings include myocardial hypertrophy, diffuse subendocardial myocyte vacuolization, and interstitial fibrosis. Myocardial ischemia, coronary artery disease, acute plaque change, coronary artery thrombosis, myocardial infarction, with muscle loss and arrhythmias, hypertrophy, dilation of viable muscle, infarct healing, ventricular remodeling, chronic ischemic heart disease, congestive heart failure, sudden cardiac death. Figure 12.18 schematic for the causes and outcomes of ischemic heart disease, showing the interrelationships among coronary artery disease, acute plaque change, myocardial ischemia, myocardial infarction, chronic IHD, congestive heart failure, and sudden cardiac death. Key concepts: ischemic heart disease. The vast majority of IHD is due to coronary artery atherosclerosis. Vasospasm, vasculitis, or embolism are less common. Causes: cardiac ischemia results from a mismatch in coronary supply and myocardial demand, and it presents as different, albeit overlapping, syndromes. Angina pectoris is chest pain on exertion due to inadequate perfusion, and is typically due to atherosclerotic disease with greater than 70% fixed stenosis. Unstable angina results from a small fissure or rupture of atherosclerotic plaque triggering platelet aggregation, vasoconstriction, and formation of a mural thrombus that needs not necessarily be occlusive. Chest pain may occur even at rest or with minimal exertion. Acute MI typically results from acute thrombosis after plaque disruption. Most occur in plaques that did not previously exhibit critical stenosis. Chronic IHD is progressive heart failure due to ischemic injury, either from prior infarctions or chronic low-grade ischemia. Myocardial ischemia leads to loss of function within 1 to 2 minutes but causes necrosis only after 20 to 30 minutes. MI is diagnosed based on symptoms, electrocardiographic changes, and measurement of serum troponins. Gross and histologic changes of infarction require hours to days to develop. Myocardial ischemia of increased severity and duration. Infarction can be modified by therapeutic intervention, which salvages myocardium at risk, but potentially induces reperfusion-related injury. Complications of infarction include ventricular rupture, papillary, muscle rupture, aneurysm formation, neurothrombus, arrhythmia, pericarditis, and CHF. Arrhythmias. Abnormalities in myocardial conduction can be sustained or sporadic. Aberrant rhythms can be initiated anywhere in the conduction system, from SA node down to the level of an individual myocyte. They are typically designated as originating from the atrium or within the ventricular myocardium. Arrhythmias can manifest as tachycardia, bradycardia, an irregular rhythm with normal ventricular contraction, chaotic depolarization without functional ventricular contraction, or no electrical activity at all. Patients may be unaware of a rhythm disorder, or may note a racing heart or palpitations. Loss of adequate cardiac output due to sustained arrhythmia can produce lightheadedness, loss of consciousness, or sudden cardiac death. Ischemic injury is a common cause of rhythm disorders, either through direct damage or through the dilation of heart chambers that alters conduction system firing. 6. Sinus syndrome. If the SA node is damaged, other fibers or even the AV node can take over pacemaker function, albeit at a much slower intrinsic rate. Atrial fibrillation. If the atrial myocytes become irritable and depolarized independently and sporadically, the signals are variably transmitted through the AV node, leading to the random irregular heart rate. Heart block. If the AV node is dysfunctional, varying degrees of heart block occur, ranging from simple prolongation of the PR interval on electrocardiogram to intermittent transmission of the signal to complete failure. As discussed earlier, coordinated cardiac contraction depends on the orderly transmission of electrical currents from myocyte to myocyte via gap junctions. Thus, abnormalities in the structure or spatial distribution of gap junctions, which are seen in a variety of disorders, can cause arrhythmias, ischemia, myocyte hypertrophy, and inflammation. Also promote increased irritability that leads to spontaneous aberrant myocyte depolarization because of the electrical interconnection of myocytes. Such random events can cause inappropriate firing of adjacent cells and create abnormal electrical circuits that lead to ventricular tachycardia, which may progress to fatal ventricular fibrillation. Likewise, deposition of non-conducting material in even small areas of fibrosis can disrupt myocyte-to-myocyte signaling, again, sowing the seeds for development of reentry circuits that can give rise to potentially fatal arrhythmias. Terrible conditions associated with arrhythmias are important to recognize because they may alert physicians to the need for intervention to prevent sudden cardiac death in the proband and their family members. Some of these disorders are associated with recognizable anatomic abnormalities. However, other heritable disorders precipitate arrhythmias and sudden death in the absence of structural cardiac pathology. These syndromes can only be diagnosed by genetic testing, which is performed in those with a positive family history or an unexplained non-lethal arrhythmia. Channelopathies are the most important of the primary electrical abnormalities of the heart that predispose to arrhythmias. Channelopathies are caused by mutations in genes that are required for normal ion channel function. These disorders either involve genes that encode the structural components of ion channels or accessory proteins that are essential for normal channel function. Ion channels are responsible for conducting the electrical currents that mediate contraction of the heart, and it is thus not surprising that defects in these channels may provoke arrhythmias. The prototype is the long QT syndrome, characterized by prolongation of the QT segment in ECGs with susceptibility to serious ventricular arrhythmias. Ion channels are needed for the normal function of Table 12.6 selected examples of causal genes and inherited arrhythmogenic disease, disorder gene function. Long QT syndrome of KCN K plus channel KCN K plus channel, SCN5 and now plus channel CAV3 Kavlin, now plus current. Short QT syndrome of KCN K plus channel KCN K plus channel. Brugada syndrome of SCN5 and now plus channel KAKN plus channel SC9 now plus channel A. CPVT syndrome of Arquo diastolic plus release CASQ diastolic plus release. LOF, loss of function mutations, DOF, gain of function mutations, CPVT, catecholinergic polymorphic ventricular tachycardia. The different mutations can cause the same general syndrome, and mutations in some genes can cause multiple different phenotypes. Thus, loss of function mutations may cause long QT intervals, whereas gain of function mutations result in short repolarization intervals. The long QT syndrome manifests as arrhythmias associated with excessive prolongation of the cardiac repolarization. Patients often present with stress-induced syncope or sudden cardiac death, and some forms are associated with swimming. Short QT syndrome patients have arrhythmias associated with abbreviated repolarization intervals. They can present with palpitations, syncope, and SCD. Brugada syndrome manifests as ECG abnormalities in the absence of structural heart disease. Patients classically present with syncope or SCD during rest or sleep, or after large meals. CPVT does not have characteristic ECG changes. Patients often present in childhood with life-threatening arrhythmias due to adrenergic stimulation. Modified from Seron M, priori SG. Genetics of sudden death. Focus on inherited channelopathies. Your heart J32, 2109, 2118, 2011. Many tissues. And certain channelopathies are also associated with skeletal muscle disorders and diabetes. Nevertheless, the most common channelopathies are isolated disorders of the heart, and their most feared consequence is sudden cardiac death. SCD typically results from ventricular fibrillation and is most frequently a consequence of CAD. Myocardial irritability typically results from non-lethal ischemia or from pre-existing fibrosis from previous myocardial injury. SCD is less often due to acute plaque rupture with thrombosis that induces a rapidly fatal arrhythmia. Sudden cardiac death. SCD is most commonly defined as unexpected death from cardiac causes, either without symptoms or within 1 to 24 hours of symptom onset. This happens in some 180,000 to 450,000 individuals each year in the United States alone. The mechanism of SCD is most often a lethal arrhythmia. Although ischemic injury can directly affect the major components of the conduction system, most cases of fatal arrhythmia are triggered by electrical irritability of myocardium distant from the major elements of the conduction system. CAD is the leading cause of SCD, responsible for the majority of cases. Unfortunately, SCD can be the first manifestation of IHD. In such cases, there is typically only chronic severe atherosclerotic disease with fixed critical stenosis. Acute plaque disruption is found in only 10% to 20% of cases, and 80% to 90% of patients who suffer SCD but are successfully resuscitated do not show any enzymatic or ECG evidence of myocardial necrosis. Healed remote MIs are present in about 40%, and subendocardial myocyte vacuolization indicative of severe chronic ischemia is a common feature. With the decrease of prevalence of IHD in high-income countries, SCD is increasingly being seen in individuals with hearts that are hypertrophic and fibrotic without IHD. With younger victims, non-atherosclerotic causes are more common etiologies for SCD. Cardiac induction abnormalities, hereditary or acquired, dilated or hypertrophic cardiomyopathy. Congenital coronary arterial abnormalities, myocarditis, mitral valve prolapse, pulmonary hypertension. Other miscellaneous causes, such as pericardial tamponade, pulmonary embolism, systemic metabolic and hemodynamic alterations, catecholamines, and drugs of abuse, particularly cocaine and methamphetamine. The prognosis of patients vulnerable to SCD is markedly improved by pharmaceutical intervention, and particularly by implantation of automatic cardioverter defibrillators that can sense and electrically counteract episodes of ventricular fibrillation. Key concepts are arrhythmias. Arrhythmias can be caused by ischemic or structural changes in the conduction system or by intrinsic myocyte electrical instability. In structurally normal hearts, Arrhythmias are often due to mutations in ion channels that cause aberrant repolarization or depolarization. Hypertensive heart disease. Hypertensive heart disease is a consequence of the increased demands placed on the heart by hypertension, causing pressure overload and ventricular hypertrophy. Although most commonly seen in the left heart as a result of systemic hypertension, pulmonary hypertension can cause right-sided HHD or cor pulmonale. Systemic hypertensive heart disease. Hypertrophy of the heart is an adaptive response to the pressure overload of chronic hypertension. However, such compensatory changes may be ultimately maladaptive and can lead to myocardial dysfunction, myocardial demand ischemia, cardiac dilation, CHF, and in some cases sudden death. The minimal pathologic criteria for the diagnosis of systemic HHD are the following: left ventricular hypertrophy in the absence of other cardiovascular pathology and a clinical history or pathologic evidence of hypertension in other organs. The Framingham study established unequivocally that even mild hypertension, if sufficiently prolonged, induces left ventricular hypertrophy. Some 30% of the population of the United States suffers from hypertension of at least this degree. More recently, the criteria for diagnosing hypertension were changed. According to the newest guidelines, diastolic pressures above 80 mmHg or systolic pressures above 120 mmHg constitute clinically significant elevations in blood pressure. On that basis, almost one-half of individuals in the general population are hypertensive. The pathogenesis of hypertension is discussed in Chapter 11. Morphology. Hypertension induces left ventricular pressure overload hypertrophy, initially without ventricular dilation. As a result, the left ventricular wall thickening increases the weight of the heart disproportionately to the increase in overall cardiac size. The heart weight may exceed 500 g, and the left ventricular wall thickness may exceed 2.0 cm. Over time, the increased thickness of the left ventricular wall, associated with increased interstitial connective tissue, imparts a stiffness that impairs diastolic filling, often leading to left atrial enlargement. Microscopically, the earliest change of systemic HHD is an increase in the transverse diameter of myocytes, which may be difficult to appreciate on routine microscopy. At a more advanced stage, variable degrees of cellular and nuclear enlargement become apparent, often accompanied by perivascular and interstitial fibrosis. A B. Figure 12.19. Hypertensive heart disease, systemic and pulmonary. Systemic hypertensive heart disease. There is marked concentric thickening of the left ventricular wall causing reduction in lumen size. The left ventricle and left atrium are on the right in this apical four-chamber view of the heart. A pacemaker is present in the right ventricle. Pulmonary hypertensive heart disease. The right ventricle is markedly dilated and has a thickened free wall and hypertrophied trachea. The shape of the left ventricle has been distorted by the enlarged right ventricle. Compensated systemic HHD may be asymptomatic, producing only electrocardiographic or echocardiographic evidence of left ventricular enlargement. In many patients, systemic HHD comes to attention because of new atrial fibrillation induced by left atrial enlargement or by progressive CHF. Depending on the severity, duration, and underlying basis of the hypertension, and on the adequacy of therapeutic control, the patient may enjoy normal longevity and die of unrelated causes, develop IHD due to both the potentiating effects of hypertension on coronary atherosclerosis and the ischemia induced by increased oxygen demand from the hypertrophic muscle, suffer renal damage or cerebrovascular stroke as direct effects of hypertension, or experience progressive heart failure or SCD. Effective control of hypertension can prevent cardiac hypertrophy and can even lead to its regression. With normalization of blood pressure, the associated risks of HHD are diminished. Pulmonary hypertensive heart disease. Normally, because the pulmonary vasculature is the low-pressure side of the circulation, the right ventricle has a thinner and more compliant wall than the left ventricle. Isolated pulmonary HHD, or cor pulmonale, stems from right ventricular pressure overload. Chronic cor pulmonale is characterized by right ventricular hypertrophy, dilation, and potentially right-sided failure. Typical causes of chronic cor pulmonale are disorders of the lungs, especially chronic parenchymal diseases such as emphysema and primary pulmonary hypertension. Acute cor pulmonale can follow massive pulmonary embolism. Nevertheless, it should also be remembered that pulmonary hypertension most commonly occurs as a complication of left-sided heart disease. Morphology. In acute cor pulmonale, there is marked dilation of the right ventricle without hypertrophy. On cross-section, the normal crescent shape of the right ventricle chamber is transformed to a dilated ovoid. In chronic cor pulmonale, the right ventricular wall thickens, sometimes up to 1.0 cm or more. More subtle right ventricular hypertrophy may take the form of thickening of the muscle bundles in the outflow tract immediately. Table 12.7 Disorders predisposing to core pulmonale diseases of the pulmonary parenchyma: chronic obstructive pulmonary disease, diffuse pulmonary interstitial fibrosis, pneumoconiosis, cystic fibrosis, bronchitis. Diseases of the pulmonary vessels: recurrent pulmonary thromboembolism, primary pulmonary hypertension, extensive pulmonary arteritis, drug, toxin, or radiation-induced vascular obstruction, extensive pulmonary tumor, microembolism. Disorders affecting chest movement: kyphoscoliosis, marked obesity, neuromuscular diseases. Disorders inducing pulmonary arterial constriction: metabolic acidosis, hypoxemia, chronic altitude sickness, obstruction of major airways, idiopathic alveolar hypoventilation. Below the pulmonary valve, or thickening of the moderator band, the muscle bundle that connects the ventricular septum to the anterior right ventricular papillary muscle. Sometimes, the hypertrophied right ventricle compresses the left ventricular chamber or leads to regurgitation and fibrous thickening of the tricuspid valve. Key concepts: hypertensive heart disease. HHD can affect either the left ventricle or the right ventricle. The latter is called core pulmonale. Elevated pressures induce myocyte hypertrophy and interstitial fibrosis that increases wall thickness and myocardial stiffness. The chronic pressure overload of systemic hypertension causes left ventricular concentric hypertrophy, often associated with left atrial dilation due to impaired diastolic filling of the ventricle. Persistently elevated pressure overload can cause ventricular failure with dilation. Core pulmonale results from pulmonary hypertension due to primary lung parenchymal or vascular disorders. There is commonly right ventricular and right atrial hypertrophy. Right ventricular and atrial dilation can occur. Valvular heart disease. Valvular disease can come to clinical attention due to stenosis, insufficiency, or both. Stenosis is the failure of a valve to open completely, obstructing forward flow. Acquired valvular stenosis is almost always due to a primary leaflet abnormality and is virtually always a chronic process. Insufficiency results from failure of a valve to close completely, thereby allowing regurgitation of blood. Valvular insufficiency can result from either intrinsic disease of the valve leaflets or disruption of the supporting structures without primary leaflet injury. It can appear abruptly, as with chordal rupture, or insidiously as a consequence of leaflet scarring and retraction. Stenosis or insufficiency can occur alone or together in the same valve. Valvular disease can involve only one valve or more than one valve. Abnormal flow through diseased valves typically produces abnormal heart sounds called murmurs. Severe lesions can even be externally palpated as frills. Depending on the valve involved, murmurs are best heard at different locations on the chest wall. Moreover, the nature and severity of the valvular disease determines the quality and timing of the murmur. The clinical consequences of valve dysfunction vary depending on the valve involved, the degree of impairment, the tempo of disease onset, and the rate and quality of compensatory mechanisms. For example, sudden destruction of an aortic valve caused by infection can cause acute, massive, and rapidly fatal aortic regurgitation. In contrast, rheumatic mitral stenosis typically develops indolently over years, and its clinical effects can be well tolerated for extended periods. Certain conditions can complicate valvular heart disease by increasing the demands on the heart. For example, the increased output demands of pregnancy can exacerbate valve disease and lead to unfavorable maternal or fetal outcomes. Valvular stenosis or insufficiency often produces secondary changes, both proximal and distal to the affected valve, particularly in the myocardium. Generally, valvular stenosis leads to pressure overload, cardiac hypertrophy, whereas valvular insufficiency leads to volume overload. Both situations can culminate in heart failure. In addition, the ejection of blood through narrowed stenotic valves can produce high-speed jets of blood that injure the endothelium or endocardium where they impact. Valvular abnormalities can be congenital or acquired. Acquired valvular stenosis is almost always a consequence of a remote or chronic injury of the valve leaflets that declares itself clinically only after many years. In contrast, acquired valvular insufficiency can result from intrinsic disease of the valve leaflets or damage to or distortion of the supporting structures. The causes of acquired heart valve diseases are summarized in Table 12.8. The most frequent causes of the major valvular lesions are as follows: aortic stenosis, calcification and sclerosis of anatomically normal or congenitally bicuspid aortic valves; aortic insufficiency, dilation of the ascending aorta, often secondary to hypertension and or aging; mitral stenosis, rheumatic heart disease; mitral insufficiency, myxomatous degeneration, or left ventricular dilation due to ischemic or non-ischemic heart failure; calcific valvular degeneration. Heart valves are subjected to high levels of repetitive mechanical stress, particularly at the hinge points of the leaflets. This is a consequence of millions of cardiac contractions per year, substantial tissue deformations during each contraction, and transvalvular pressure gradients in the closed phase of each contraction of approximately 120 mmHg for the mitral and 80 mmHg for the aortic valve. It is therefore not surprising that these delicate structures can suffer cumulative damage and calcification that lead to clinically important dysfunction. Calcific aortic stenosis, the most common of all valvular abnormalities. Calcific aortic stenosis is usually the consequence of age-associated wear and tear of either anatomically normal valves or congenitally bicuspid valves. The prevalence of aortic stenosis is estimated at 2% and is increasing as the general population ages. Aortic stenosis of previously normal valves usually comes to clinical attention in the 7th to 9th decades of life, whereas Table 12.8 Etiology of acquired heart valve disease, mitral valve disease, aortic valve disease, mitral stenosis, aortic stenosis, post-inflammatory scarring, post-inflammatory scarring, senile calcific aortic stenosis, calcification of congenitally deformed valve, mitral regurgitation, aortic regurgitation, abnormalities of leaflets, and intrinsic valvular disease. Commissure's post-inflammatory scarring, infective endocarditis, mitral valve prolapse, aortic disease, fen, induced valvular degenerative aortic dilation. Fibrosis, syphilitic aortitis, abnormalities of tensor ankylosing spondylitis, apparatus rheumatoid arthritis, rupture of papillary muscle, Marfan syndrome, papillary muscle dysfunction. Rupture of chordae tendineae, abnormalities of left ventricular cavity and / or annulus, left ventricular enlargement, calcification of mitral ring, fenfluramine, fentanyl. Data from Scone F.J. Surgical pathology of removed natural and prosthetic valves, Pathol 1855 8, 567, 1987. Stenotic bicuspid valves tend to become clinically significant 1 to 2 decades earlier. Aortic valve calcification is likely a consequence of recurrent chronic injury due to hyperlipidemia, hypertension, inflammation, and other factors similar to those implicated in atherosclerosis. The chronic progressive injury leads to valvular degeneration and incites the deposition of hydroxyapatite. Although this model provides a good starting point for understanding calcific degeneration, it is increasingly clear that the valve injury of calcific aortic stenosis differs in some important respects from atherosclerosis. Most notably, the abnormal valves contain cells resembling osteoblasts that synthesize bone matrix proteins and promote the deposition of calcium salts. Moreover, interventions that improve atherosclerotic risk do not appear to significantly prevent valvular calcific degeneration. Bicuspid valves incur greater mechanical stress than normal tricuspid valves, which may explain their accelerated stenosis. Morphology. The gross morphologic hallmark of non-rheumatic calcific aortic stenosis is mounted calcified masses on the outflow surfaces of the cusps that ultimately prevent cuspal opening. The free edges of the cusps are usually not involved. Microscopically, the layered architecture of the valve is largely preserved. The calcific process begins in the valvular fibrosa on the outflow surface of the valve, at the points of maximal cusp flexion. Inflammation is variable, and metaplastic bone can be seen. In aortic stenosis, the functional valve area is decreased by large nodular calcific deposits that can eventually cause measurable outflow obstruction. This subjects the left ventricular myocardium to progressively increasing pressure overload. In contrast with rheumatic aortic stenosis, commessural fusion is not usually seen. Clinical features in calcific aortic stenosis. The obstruction of the left ventricular outflow leads to gradual narrowing of the valve orifice and an increasing pressure gradient across the calcified valve. Left ventricular pressures rise to 200 mmHg or more in such instances, producing concentric left ventricular hypertrophy. The hypertrophied myocardium tends to be ischemic, and angina pectoris may occur. Both systolic and diastolic myocardial function may be impaired. Eventually, cardiac decompensation and CHF can ensue. The onset of symptoms in aortic stenosis heralds cardiac. A BCD. Figure 12.20 Calcific valvular degeneration. Calcific aortic stenosis of a previously normal valve. Nodular masses of calcium are heaped up within the sinuses of valve. Note that the commissures are not fused, as occurs with post-traumatic aortic valve stenosis. Calcific aortic stenosis of a congenitally bicuspid valve. One cusp has a partial fusion at its center, called a RAF. Mitral annular calcification, with calcific nodules at the base of the anterior mitral leaflet. Left atrial view. Cut section of myocardium showing the lateral wall with dense calcification that extends into the underlying myocardium. Decompensation and carries an extremely poor prognosis. If untreated, most patients with aortic stenosis will die within 5 years of developing angina, within 3 years of developing syncope, and within 2 years of CHF onset. Treatment requires surgical valve replacement, as medical therapy is ineffective in severe symptomatic aortic stenosis. Calcific stenosis of congenitally bicuspid aortic valve. Bicuspid aortic valve is a developmental abnormality with prevalence in the population of approximately 1%. Calcified BAV comprises approximately 50% of cases of aortic stenosis in adults. Some cases of BAV show familial clustering, often with associated aortic or left ventricular outflow tract malformations. Loss of function mutations in NOC have been specifically associated with BAV in a few families. In a congenitally bicuspid aortic valve, there are only two functional cusps, usually of unequal size, with the larger cusp having a midline raphe, resulting from incomplete commissural separation during development. Less frequently, the cusps are of equal size and the raphe is absent. The raphe is frequently a major site of calcific deposits. Although BAV is usually asymptomatic early in life, the onset of calcific degeneration heralds a clinical course similar to that described earlier for calcific aortic stenosis. Other bicuspid valve complications include aortic regurgitation and infective endocarditis. Interestingly, structural abnormalities of the aortic wall also commonly accompany BAV, even when the valve is hemodynamically normal, and this may potentiate aortic dilation or aortic dissection. Mitral annular calcification as opposed to the predominantly cuspal involvement in aortic valve calcification, degenerative calcific deposits in the mitral valve typically develop in the fibrous annulus. Grossly, these appear as irregular, stony hard, occasionally ulcerated nodules at the base of the leaflets. Mitral annular calcification usually does not affect valvular function. However, in exceptional cases it can lead to the following: regurgitation by interfering with physiologic contraction of the valve ring, stenosis by impairing opening of the mitral leaflets, arrhythmias and occasionally sudden death by penetration of calcium deposits to a depth sufficient to impinge on the atrioventricular conduction system. Because calcific nodules may also provide a site for thrombus formation, patients with mitral annular calcification have a mildly increased risk of embolic stroke, and the calcific nodules can become a nidus for infective endocarditis. Mitral annular calcification increases with age and is more common in women and individuals with mitral valve prolapse. Mitral valve prolapse. In mitral valve prolapse, one or both mitral valve leaflets are floppy and protrude into the left atrium during systole. MVP affects approximately 2% to 3% of adults in the United States and is more common in women. It is most often an incidental finding on physical examination, but may lead to serious complications in a small minority of affected individuals. Pathogenesis: the etiologic basis for the changes that weaken the valve leaflets and associated structures is unknown in most cases. Uncommonly, MVP is associated with heritable disorders of connective tissue including Marfan syndrome, caused by fibrillin-1 mutations that alter cell matrix interactions and dysregulate TGF-beta signaling. Interestingly, mice with mutated FB9 develop a form of MVP that is prevented by TGF-beta inhibitors, indicating that excess TGF-beta activity can cause the characteristic structural laxity and myxomatous changes. Morphology: the characteristic anatomic change in MVP is ballooning of the mitral leaflets. The affected leaflets are often enlarged, redundant, thick, and rubbery. The associated tendinous cores may be elongated, thin, or even ruptured, and the annulus may be dilated. The tricuspid, aortic, or pulmonary valves may also be affected. The key histologic change in the tissue is marked myxomatous degeneration of the spongiosal layer, reflected by increased deposition of a highly sulfated hydrophilic matrix, the collagenous fibrosa. Layer of the valve is also attenuated, affecting the structural integrity of the leaflet. Secondary changes reflect the stresses in tissue injury incident to the billowing leaflets. Fibrous thickening of the valve leaflets, particularly where they rub against each other. Linear fibrous thickening of the left ventricular endocardial surface where the abnormally long cords snap or rub against it. Thickening of the mural endocardium of the left ventricle or atrium as a consequence of friction-induced injury induced by the prolapsing, hypermobile leaflets. Thrombi on the atrial surfaces of the leaflets or the atrial walls, and focal calcifications at the base of the posterior mitral leaflet. Notably, mitral valve myxomatous degeneration can also occur as a secondary consequence of regurgitation of other etiologies. Clinical features: most individuals diagnosed with MVP are asymptomatic. In such cases, the condition is discovered incidentally by auscultation of mid-systolic clicks, caused by abrupt tension on the redundant valve leaflets and chordae tendineae as the valve attempts to close. There may or may not be an associated regurgitant murmur. The diagnosis is confirmed by echocardiography. A minority of patients have chest pain mimicking angina, and a subset has dyspnea, presumably related to valvular insufficiency. Although the great majority of persons with MVP have no untoward effects, approximately 3% develop one of four serious complications: infective endocarditis, mitral insufficiency, sometimes with chordal rupture, stroke or other systemic infarct, resulting from embolism of leaflet thrombi, or arrhythmias, both ventricular and atrial. Rarely, MVP is the only finding in sudden cardiac BADE. Figure 12.21 myxomatous degeneration of the mitral valve. Long axis view demonstrating hooding with prolapse of the posterior mitral leaflet into the left atrium. Open valve, showing pronounced hooding of the posterior mitral leaflet with thrombotic plaques at sites of leaflet left atrium contact. Open valve with pronounced hooding in a patient who dies suddenly. Note also mitral annular calcification on the left side. Normal heart valve in myxomatous mitral valve. In myxomatous valves, collagen in the fibrosed layer is loose and disorganized. Chronoglycan deposition in the central spongiosal layer is markedly expanded, and elastin in the atrialis layer is disorganized. From Rack and E. et al. Activated interstitial myofibroblasts express catabolic enzymes and mediate matrix remodeling in myxomatous heart valves. Circulation 10 for 2525, 2532, 2001. Death, valve repair or replacement surgery can be done for symptomatic patients or those with increased risk for significant complications. Rheumatic fever and rheumatic heart disease. Rheumatic fever is an acute, immunologically mediated, multisystem inflammatory disease classically occurring a few weeks after group of streptococcal pharyngitis. Occasionally, RF can follow streptococcal infections at other sites, such as the skin. Acute rheumatic carditis is a common manifestation of active RF and may progress over time to chronic rheumatic heart disease. RHE is characterized principally by deforming fibrotic valvular disease, particularly involving the mitral valve. Indeed, RHE is virtually the only cause of mitral stenosis. The incidence and mortality rate of RF and RHD have declined remarkably in many parts of the world over the past century as a result of improved sanitation and rapid diagnosis and treatment of streptococcal pharyngitis. Nevertheless, in low-income countries and in many crowded, economically depressed urban areas, RHE remains an important public health problem. Pathogenesis. Acute rheumatic fever results from host immune responses to group of streptococcal antigens that cross-react with host proteins. The characteristic 2 to 3 week delay in symptom onset after infection is explained by the time needed to generate an immune response. In particular, antibodies and CD4 plus T cells directed against streptococcal M proteins can also in some cases recognize cardiac self-antigens. Antibody binding can activate complement as well as recruit F receptor-bearing cells. Cytokine production by the stimulated T cells leads to macrophage activation. Damage to heart tissue may thus be caused by a combination of antibody and T cell mediated reactions. In keeping with an immunologic basis of RHD, streptococci are completely absent from the lesions. Because only a small minority of infected patients develop rheumatic fever, the genetic susceptibility is likely to influence the development of the cross-reactive immune responses. The chronic fibrotic lesions are the predictable consequence of healing and scarring associated with the resolution of the acute inflammation. Morphology. Key pathologic features of acute RF and chronic RHD are shown in Fig. 12.22. During acute RF, focal inflammatory lesions are found in various tissues. Distinctive lesions in the heart, called Asheville bodies, are composed of foci of T lymphocytes, occasional plasma cells, and plump activated macrophages called Anichkow cells. These macrophages have abundant cytoplasm and central round or ovoid nuclei in which the chromatin condenses into a central, slender, wavy ribbon. During acute RF, diffuse inflammation in Asheville bodies may be found in any of the 3 layers of the heart, resulting in pericarditis, myocarditis, or endocarditis. Inflammation of the endocardium and the left-sided valve typically results in fibrinoid necrosis within the cusps or tendinous. 8. CDE Figure 12.22. Acute and chronic rheumatic heart disease. Acute rheumatic mitral valvulitis superimposed on chronic rheumatic heart disease. Small vegetations are visible along the line of closure of the mitral valve leaflet. Previous episodes of rheumatic valvulitis have caused fibrous thickening and fusion of the chordae tendineae. Microscopic appearance of an Asheville body in a patient with acute rheumatic carditis. The myocardium exhibits a circumscribed nodule of mixed mononuclear inflammatory cells with associated necrosis. Within the inflammation, large activated macrophages show prominent nucleoli, as well as chromatin condensed into long, wavy ribbons. Mitral stenosis with diffuse fibrous thickening and distortion of the valve leaflets and commissural fusion and thickening of the chordae tendineae. Note the neovascularization of the anterior mitral leaflet. Surgically resected specimen of rheumatic aortic stenosis, demonstrating thickening and distortion of the cusps with commissural fusion. RHD-IMBT LSC. Figure 12.23. Comparison of the 4 major forms of vegetative endocarditis. The rheumatic fever phase of rheumatic heart disease is marked by small, warty vegetations along the lines of closure of the valve leaflets. Infective endocarditis is characterized by large, irregular masses on the valve cusps that can extend onto the chordae. Non-bacterial thrombotic endocarditis typically exhibits small, bland vegetations, usually attached at the line of closure. One or many may be present. Lehmann-Sachs endocarditis has small or medium-sized vegetations on either or both sides of the valve leaflets. cords. Overlying these necrotic foci and along the lines of closure are small vegetations, called verci. Thus, RHE is one of the forms of vegetative valve disease, each of which exhibit their own characteristic morphologic features. Subendocardial lesions, perhaps exacerbated by regurgitant jets, can induce irregular thickenings called McCallum plaques, usually in the left atrium. The cardinal anatomic changes of the mitral valve in chronic RHE are leaflet thickening, commensural fusion and shortening, and thickening and fusion of the tendinous cord C. Fig. 12.22d. The mitral valve is virtually always involved in chronic RHD. It is affected in isolation in roughly 2/3 of cases, along with the aortic valve in another 25%. Tricuspid valve involvement is infrequent, and the pulmonary valve is only rarely affected. In rheumatic mitral stenosis, calcification and fibrous bridging across the valvular commissures create fish mouth stenosis. With tight mitral stenosis, the left atrium progressively dilates.